Good to go. Good to go, sir.
Right. So, good evening, friends. On behalf of Cardiology Society of India Pune branch, I welcome you all to the annual conference of CSI. For more than 25 years, the annual CSI conference has been an important event on the scientific calendar, which the physicians and cardiologists of Western India eagerly look forward to. This year, we have an academic feast lined up for you with world-renowned speakers, both nationally and internationally, deliberating on important topics which we all come across in our day-to-day practice. Today, we are going to listen to and learn from very eminent international speakers who are masters in their own respective fields. We have with us Dr. Patrick Serres, considered to be the father of interventional cardiology, and cardiologists of my generation especially have grown up learning the interventional skills from Dr. Patrick Serres. He's going to join us from Galway, Ireland, and is going to speak on CABG versus PCI in patients with triple vessel disease. Then we have Dr. John McMurray, who is one of the pioneers in the field of heart failure, and he's going to join us from Glasgow, United Kingdom. Remember, he is the one, along with Dr. Milton Packer, who introduced the term rapid sequencing in heart failure. Then joining us from United States is Dr. Manish Patel, a very decorated cardiologist from the Duke University, and he is going to talk on the role of NOACs in patients with atrial fibrillation. We have an equally distinguished national faculty with us today in Dr. Ajit Bhagwat, with whom we have interacted so many times on this platform, and it is always a pleasure listening to him. Dr. J.P. Sahni, the lipid guru of India, and we have all enjoyed his talk, especially during one of our monthly meetings, and I thought that it to be appropriate that this audience also benefits from the vast experience that Dr. Sahni brings from the field of lipidology. Lastly, but not the least, we have our own versatile, extremely gifted Dr. Sunil Sathe, who's going to talk on markers of sudden cardiac death. To take us through this academic session, we have a very distinguished panel of moderators who are senior cardiologists of the city, and they would be sharing their thoughts and experiences as we go along. This annual conference is a culmination of the academic year, and I must congratulate Dr. Rahul Patil for doing an excellent job as CSI Secretary. And we have both been at the helm of this organization for the last 3 years, and we have absolutely enjoyed bringing all the academic activities, whether it was physical activities before the pandemic or the virtual meetings during the pandemic. We would also like to thank our academic partners, especially Emcure Pharmaceuticals, led ably by Mrs. Namita Thapar, Bayer Pharmaceuticals, and Abbott Vascular for their continued support during this journey. We are having this particular academic session on the Zoom platform, and I'm sure we are all familiar with the Zoom platform. And I request all the delegates, whatever questions they have, to kindly put them down in the chat box so that we ensure that most of the questions are answered by the distinguished panel. So I request you to kindly sit back, relax, and enjoy this academic feast. And to let's set the ball rolling, we have the first speaker in Dr. Ajit Bhagwat, and he's going to speak to us on cardiac fitness for non-cardiac surgeries. Dr. Ajit Bhagwat is the Director of Cardiac Cath Lab, Kamal Nayan Bajaj Hospital, Aurangabad. He is Diplomat of American Board of Cardiology. He has been President of Indian Society of Electrocardiology 2021 and has received the Best Reviewer Award of Indian Heart Journal in 2015. He has more than 85 publications and abstracts to his credit and has been a principal investigator of many international trials such as Tuxedo 1 and 2, Emperor Reduced, Emperor Preserved trials, and so on. The moderator for this session is Dr. Shirish Sathe, is a very senior interventional cardiologist of the city and head of...
Sorry to interrupt, but your slides are not visible.
No, we have not started yet.
Oh, you're not started yet. Okay.
No.
But
the moderator of the session is Dr. Shirish Tathe. He is a very senior interventional cardiologist of the city, and he is the head of department of Dinanath Mangeshkar Hospital. He has been practicing in Pune for more than 30 years and conducts the DNB cardiology program at the Mangeshkar Hospital and is a principal investigator of multiple international clinical trials and also conducts the heart failure clinic at DMH. So I now hand it over to Dr. Shirish Tathe to continue with the proceedings and invite Dr. Ajit Bhagwat for his talk. Dr. Tathe, please.
Hello, can you hear me?
Yeah.
Yeah. At the outset, I must congratulate Rajiv and Rahul to organize this kind of a meeting over last 3 years again and again. And this meeting also won't be different. We'll have a feast of knowledge today. We start with Dr. Ajit Bhagwat, who, as we all know, doesn't need any introduction because he's been on this platform with us for many times. So without further ado, I would like to ask Dr. Ajit Bhagwat to start with this talk. Ajit.
Thank you. Am I audible?
Yes.
Okay. I will share the screen now. Can you see the screen?
Yes, sir. Yes.
Okay. Good evening, everybody. So at the outset, I would like to thank Dr. Rajiv Sethi, Dr. Rahul Patil, and members of Cardiological Society of India, Pune, for inviting me for this August meeting. And I would also like to congratulate the organizers for taking up this topic, which is very, very important bread and butter topic for everybody, for physicians, for cardiologists, because virtually every day you get 1 or 2 patients for whom you are asked to give preoperative clearance. Now, one often uses this term of preoperative fitness. Now, I have some serious objections to this word fitness because there is nothing like fit or unfit for surgery. I mean, what you generally do is basically risk stratify the patient. So basically, in a given situation, you want to do the best for the patient to give recommendations and to do assessment, which will help in getting the best possible outcome after surgery. So it's not like cricket match where a player is fit or unfit for a given situation. So what are you really being asked to do? Basically, you have to assess the risk of anesthesia, assess the risk of procedure, manage the complicated medical problems which are associated with the patient, like diabetes or hypertension or any other medical problems, and predict the future, what's going to happen during surgery. Now, Kim Eagle, who was the ACC-AHA Task Force chairman, had concluded his chapter by this statement that the purpose of preoperative evaluation is not to give medical clearance, but rather to perform an evaluation of the patient's current medical status, make recommendations concerning the evaluation, management, and risk of cardiac problems over the entire perioperative period, and provide a clinical risk profile that the patient, primary physician, anesthesiologist, and surgeon can use in making treatment decisions. So it's a process. It involves many things. It's not just black and white, fit, unfit. It's basically a risk stratification and the recommendations. Now, let's start with the incidence and mechanism of perioperative cardiac events. Now, the rate of cardiac complications, the rate of death after major surgeries is about 0.5%. Most of the big series are close to this figure. And the 30-day incidence of myocardial infarction is about 2%, 30 days after surgery. Now, patients with underlying cardiovascular disease in any vascular bed are at higher risk. And patients with coronary artery disease have, elderly patients or patients who are undergoing major surgery have higher incidence of coronary artery disease and left ventricular dysfunction. Now, it is very interesting to note that if you read the recent literature, you can see this particular difference that the type 1, that is plaque rupture myocardial infarction, is decreasing, while the type 2, that is hemodynamic myocardial infarction, is on the rise in perioperative period. Now, this could be because of better care, better medicines, better recommendations made by the cardiologists or physicians, but so that the plaque rupture is reduced incidence, but hemodynamic MIs, which are mainly because of supply-demand imbalance, are seen to be occurring with increasing frequency. Now, what is so special about surgery? I mean, why are we worried about surgery? What is special about surgery that predisposes the patient to cardiac events? One is anesthesia. It's a stress situation. Anesthesia, bleeding, a number of fluid shifts which occur. A lot of fluid shift occurs during surgery. There is a lot of tissue injury, and many tissue factors are released in the blood, many of which are, they promote coagulation. There is a lot of perioperative pain, and which results, all these things result in changes in heart rate and blood pressure, resulting in sometimes acute cardiac events and some occasionally death. Now, I look at this problem in this particular manner. Any medical situation is a combination of host, agent, and environment factors. Unless these three things together come together, a medical event rarely occurs. Now, when you combine patient and surgery factors, patient is host, surgery and surgeon are the agents. So you take these two for risk assessment. And when you want to recommend something, that is the environment is pre, intra, or post-operative management. So basically for risk assessment, it's patient and surgery surgeon. And for your action, it's pre-operative, intraoperative, and post-operative period. Now, what are the surgical factors? Let's start with the surgical factors. Okay. Now, what are the high-risk surgeries? Which should always raise an antenna as soon as you hear this: intraperitoneal surgery, thoracic surgery, and suprainguinal vascular surgery. Now, some of the surgeries which are associated with a very high risk of perioperative cardiac events are surgeries like aortic aneurysm or dissection of aorta. Now, what about the duration of anesthesia? No, this was published in 1999 in Archives of Internal Medicine, that the duration of anesthesia was directly proportional to the complications. Now, here I'm not talking about MIs or deaths. Here they have taken every complication, even a small complication like wound infection or wound dehiscence, pulmonary complications, aspiration, everything. And you can see that the longer the anesthesia, the percentage of complications goes on increasing very significantly. Now, this is another thing which we never take into account, but this is always at the back of our mind. Who is the surgeon? Now, if the surgeon is, surgeons have reputation. Some surgeons are very fast, very quick, and some surgeons, are very slow, and the complications are more likely when the surgeon is, below par. It results, when the surgeon is below par, it results in more tissue injury, more bleeding, longer anesthesia, and longer operation. Now, I'm not trying to say that you can do anything about the surgeon, anything about the situation. You cannot change the surgeon, but it should be at the back of your mind. And you may want to, discuss the situation with the surgeon before he undertakes a major vascular surgery or major surgery in a high-risk patient. Now, what are the patient factors? Now, when we're talking about the patient factors, these are the 6 things which one must remember. It should be at the tip of our mind, of our tongue. History of ischemic heart disease, particularly in last 6 months. History of heart failure, history of stroke or TIA, insulin requiring diabetes, chronic kidney disease with creatinine of more than 2 or eGFR less than 40, and the patient who is undergoing high-risk surgery, which we have already talked about. Now, these are 6 high-risk factors. Now, atrial fibrillation and obesity also add to this risk, and it should be at the back of your mind. Although the literature is not very clear about whether your recommendation should be, very different in obese patients. Now, you can see the number of risk factors which we already enumerated, and the complications, the major cardiac complications here. We're talking about cardiac complications. You can see that in all types of surgeries, abdominal aortic aneurysm, vascular surgery, thoracic, abdominal, orthopedics, and everything, the higher the number of risk factors, the higher is the complication rate. Now, one of the most important factors which is going to determine the outcome after non-cardiac surgery is effort tolerance of the patient. And one should go out of his way, sometimes spend more time than usual to find out what is the effort tolerance of the patient who is going to undergo this surgery. Now, this is the table which tells you the activities and the required oxygen consumption, which we call MET. 1 MET is required for watching TV, and then as you go up, desk work, moderate walking, bicycling, jogging, and then the number of METs required for that activity, they start going up. For rope jumping or push-ups or pull-ups, it's about 8 to 10 METs. Now, 1 MET is about 3.5 ml per kg per minute of oxygen consumption. Now, inability to perform 4 METs is associated with increased perioperative risk. This has been an established number. Everybody must remember this number. 4 METs is a magic number. One should try to find out whether the patient is able to perform 4 METs of activity, and it makes your life very easy if you determine this correctly. Patients who cannot walk more than 400 meters or cannot climb 2 flights of stairs, you can roughly say that they cannot perform more than 4 METs. Now, this is little controversial because there are some papers which suggest that just subjectively you cannot determine patients' effort tolerance in terms of METs. We'll talk about it. Now, this is one study which was published in Lancet in 2018, where they studied about 1,400 patients over 40 years who are going to undergo major surgery and had at least one risk factor, which we just talked about. And they did subjective assessment. They also gave them questionnaire, written questionnaire. Then they performed cardiopulmonary exercise testing. They actually measured the VO2 max, and they also measured NT-proBNP in those patients. All these 4 things were done on all patients. And they looked at what happened to the surgical outcome. And the important thing was, their conclusion was subjective assessment correctly identified only 16% of patients who achieved a peak less than 14 ml per kg, that is 4 METs, which is consistent with less than 4 metabolic equivalents. So the accuracy of this assessment, subjective assessment, is not that great. But there are enough number of experts who say that if you really sit with the patient and take good history, most of the times you will be able to find out. Just cursory questions, 1 or 2 questions may not be able to give you the accurate assessment. And if you are in doubt, put the patient on treadmill if it is possible. Now, what are the very high risk conditions which where the risk is almost prohibitive? Risk of doing a non-cardiac surgery. It's like acute coronary syndrome, a very recent MI, decompensated heart failure, severe valvular disease, particularly stenotic lesions, significant arrhythmias, and atrioventricular blocks, etc. Now, here, these conditions should be treated before elective surgery. Now, what about emergency surgery? We'll talk about it. But if the surgery is elective, fix these problems before patient goes for surgery. Now, before we talk about different surgeries, we need to define certain terms. And that is very important. What is emergency? Emergency is when threat to life or limb if patient is not operated upon within 6 hours. What is urgent? When the patient needs to be operated within 6 to 24 hours. What is time-sensitive surgery? Where a delay of more than 1 to 6 weeks could negatively affect the outcome. And most of the oncological procedures fall into this. A patient with cancer, you don't want to wait too long. I mean, nothing is going to happen in 24 hours, but waiting for too long may result in adverse outcome in terms of his cancer. Now, what is elective surgery? 1 year is generally considered as elective, where you can safely wait for a year. There are some low-risk procedures where the adverse event rate is less than 1%, like cataract and plastic surgery. and surgeries where the risk is more than 1%. And I've already defined very major risk surgeries like suprainguinal vascular surgeries, intraperitoneal surgeries, etc. Now, let's start with the ECG. This is the most commonly advised test. Should we advise it? It is not recommended in asymptomatic patients with low risk profile. Okay, but it's okay to get an ECG in an elderly patient if ECG was never done in the past. I think it makes common sense that if you have a 70-year-old gentleman going for a major surgery, ECG is an easy, non-invasive, inexpensive way. It gives you a lot of information. And most do it to have something for comparison in case ECG is required post-operatively. I know you don't run around. If post-operative ECG shows T inversion, if you have a pre-operative ECG, life becomes easy. So even if it's not recommended, I would recommend it in every patient who is an elderly patient, particularly when a recent ECG is not done. What about an echo? It's not indicated in asymptomatic patients with no history of heart failure and normal auscultation. Now, this is very important because most of the people don't end up auscultating the patient. And I think one of the areas where auscultation is most important is preoperative evaluation, because unless you are advising echo for every patient, normal auscultation rules out major cardiac conditions. It's reasonable to do an echo in patients with abnormal ECG and no echo in the past. If ECG is abnormal, it's any kind of abnormality, and no echo has been done in the past, it's quite reasonable to do it. Patients with unexplained dyspnea should undergo it, and it's again simple, inexpensive, and non-invasive test. So important to remember that echo could be sometimes important, but I see that in practice, I know almost everybody undergoes an echocardiogram before surgery. Now, exercise stress test, is it indicated for assessing functional status when it cannot be assessed by subjective assessment or by questionnaire? So sometimes it's very difficult to assess. Patient may be sometimes a poor historian. He may not be able to give a good history. Sometimes giving a questionnaire may not help. In that situation, doing a treadmill test will give you some objective assessment, and it gives you, exercise tolerance in METs. It should not be done for inducible ischemia unnecessarily. It should be done for inducible ischemia only if it is independently indicated, not for not as pre-operative assessment. We'll talk about it. Non-invasive testing is to be done only if it is indicated independent of surgery. For example, patient who has got typical angina or recent onset dyspnea or syncope which is bothersome, or when functional status cannot be assessed. It should be performed in a case with good functional status. Now, these are the tests: TMT, dobutamine echo, or a perfusion scan. Now, these all of you know. Now, can we come up with an algorithm for preoperative cardiac assessment? Well, yes. Patient who has got risk factors is scheduled for surgery. Is it an emergency? Yes. Then just risk stratify and proceed for surgery. Talk to the surgeon and anesthesiologist that his preoperative risk is high, and you take all the precautions which are required. If it is non-emergent, then manage his diabetes, hypertension, other risk factors properly. And if the patient has elevated risk, we have already seen the risk factors. And if he can perform 4 METs function capacity, he goes for surgery. If he cannot perform 4 METs, then you decide whether further testing is going to change the management. If yes, you do some pharmacology stress test like dobutamine, echo, or perfusion scan, revascularize, and then patient goes for surgery. We'll talk about revascularization a bit later. Now, this is an important table which I have made, after going through the literature. This is a revascularization indication, this is surgical indication, and this is the decision you make. Now, if you have a patient with elective revascularization indication, like patient has chronic stable angina for 2 years, 1 year, and he is to undergo surgery for perforation peritonitis. Now, here you are not going to spend much time on his angina. Patient goes for surgery. If the revascularization indication is elective and surgical indication is time sensitive, say for example patient has cancer, then you have to take a case-based approach. Whether doing the revascularization is important or operating for, for his cancer is important. Here, I many times perform coronary angiography in these patients. And if the patient does not have left main or does not have proximal LAD, just you find some distal disease or you find some chronic occlusions which are collateralized, don't do an angioplasty on these patients because you will have a stent and you will complicate the issue of postoperative management. You send the patients for surgery in this patient. So take case-based management decisions. If both are elective, revascularization should take precedence. If patient has hernia and angina, revascularization should take precedence. If both are emergent, again, you have to take case-based decisions. Now, this situation is rare, but I have faced this situation once or twice. Patient has, some acute abdominal emergency and ECG shows deep T inversion in anterior chest leads. What are you going to do? You have to increase troponin. In this situation, I think, heart must take precedence. You have to take the patient to the cath lab, open the artery which is giving him ischemia, and talk to the surgeon about antiplatelet management, and then send the patient for surgery. But these are rare situations. When the revascularization indication is emergent and the surgical indication is time sensitive or elective, revascularization should always take precedence. Now, what are the low risk procedures? No workup is required for low risk procedures like cataracts and dental procedures. Reasonable blood pressure and blood sugar should be maintained. Rule out active high risk condition like acute coronary syndromes or heart failure. A history and physical examination is good enough. Referral is usually done for sharing risk. The ophthalmologist will still ask you to give fitness or whatever, and that is only to share the risk. Now, do not suggest the type of anesthesia. There are certain things you should not do. Don't write, avoid hypotension and hypoxia. That's the most unintelligent thing that one can do. I mean, nobody, produces hypotension and hypoxia. Everybody knows to avoid it. Change ongoing treatment plans. Just don't change the surgeon's treatment plans. And don't initiate a diagnostic workup just because the patient has been referred to you for clearance. A diagnostic workup should be limited to the problem. Now, general consideration, limit number of recommendations, focus on critical problems, be specific about drugs, dosages, and intervals, and don't ask surgeon to think. Elective non-cardiac surgery after PCI. Now, this is very common, this problem. It should be delayed for at least 6 to 12 months after placing a drug-eluting stent, for about 1 month after BMS, and for about 2 weeks after balloon angioplasty. Now, these are the standard numbers which one must remember. Now, this is the protocol. When patient has a coronary stent and is going for surgery. Now, if the stent was recently deployed and surgery is elective, you can delay the surgery for 30 days for the BMS and 1 year for DES. If the surgery is not elective, then you have to continue dual antiplatelet therapy unless the risk of bleeding is prohibitively high. And in that situation, you have to sit with the surgeon, the patient's family, anesthesiologist, and discuss the risk of discontinuing maybe one antiplatelet agent so early after stenting. If the stenting is done remotely, say within last 1 year but more than 30 days, then it becomes risk stratification. If you can delay the surgery, it's always better. If surgery cannot be delayed within 6 months, it's quite reasonable with a surgical indication of 2B. If the stenting has been done very remotely, say before 1 year or more than 1 year ago, then you can always sit down and consider the risk of bleeding versus the risk of clotting in that situation. Many times in that situation, the risk of bleeding is high because the surgical risk is quite high in many surgeries. And in that situation, you can continue aspirin, discontinue one of the other antiplatelet agents, and ask the surgeon to proceed for surgery. Now, this is one drug which has recently come, which is cangrelor. Now, here, sometimes you get a situation where angioplasty has been done in, say, last 2 months. Patient has a stent and is going for a major surgery where surgical risk of bleeding is quite high. Now here you can use this drug. Uh, Now here you want a situation where patient is off antiplatelet drugs for a very short time, as short as possible, and you at the same time you can provide the surgeon with a small window where there is no antiplatelet therapy on board, and surgeon can operate with a relative impunity. Now here is the protocol. In that situation, you can low dose aspirin needs to be continued. If the patient is on prasugrel, you stop it 7 days before. If you're on ticagrelor or clopidogrel, you stop it 5 days before. And then on day -3, you can start cagrelor. Cagrelor infusion for 12-hour infusion in this dose will cost you 12,000 rupees per day. But it's maybe it's worth it if you want to avoid the risk of a catastrophe. Then stop the infusion for about maybe 6 to 10 hours before the major surgery, and then you give the antiplatelet agent action is gone, and the surgeon can take the patient for surgery, and then once the hemostasis is achieved, you can restart the patient on clopidogrel. Don't start prasugrel or tica because they are potent. When you restart the patient, start clopidogrel. If the patient has an NG tube and cannot take orally, then you can assess the bleeding risk and start the patient again on cangrelor. So this new drug, which can be given IV, has proved to be very, very useful. Now, what about perioperative beta blockers? These are my last few slides. Continue in those who are chronically on it. It's reasonable to begin beta blockers in high-risk cases to prevent perioperative ischemia or perioperative cardiac events. It should preferably be started 1 day before surgery to assess safety and tolerability. Never start beta blocker on the day of surgery. It's not very wise to do it. But there are many papers in the literature which show that perioperative beta blockers help in reducing cardiac events. Perioperative statins, there is not a whole lot of data on this. There are some papers which suggest that using statins may be useful here, but statins are recommended in so many conditions that you stop counting those indications for statins now. Revascularization. No study has shown that elective revascularization reduces the risk of perioperative MACE. So preoperative revascularization is recommended only if it is independently indicated and is non-cardiac surgery can be safely delayed. Now let's take last 3 cases before I stop. A 61-year-old diabetic patient needs Whipple surgery for CA pancreas, and he has effort angina for last 6 months with recent increase in intensity and decrease in pain threshold. ECG and echo are normal. The cancer surgery as soon as possible is one choice. Decision after angiography is another choice. Intensive medical treatment of coronary artery disease and cancer surgery is the last choice. Now, there are no black and white answers here. I mean, one cannot say this is the answer. Here you have to use your judgment and talk to the family and talk to the surgeon that this Whipple's is a major surgery. I mean, it takes hours. If the surgeon is slow, it will take hours together. Now, this is a time-sensitive situation where patient has cancer pancreas. Hopefully, there are no Mets already. I mean, I'm sorry. If he's Mets, he won't be operated. But the cancer is, hopefully resectable or whatever. Here, what I would suggest is what I generally do. If the patient has angina, if the patient has stable angina for last 2 years and no change, I would send the patient for surgery. But if there is recent increase in intensity, maybe some minor ECG changes, I will take the patient for angiography. If there is no left main or proximal LED lesion, you can wait and you can think about the situation. There are many times you see a chronic total occlusion which is collateralized. There are situations where the lesion is distal, the plaque root looks pretty stable. In this situation, you don't want to go ahead and put a stent. Because once you put a stent, the surgeon is going to be very unhappy with you, and the patient is going to be on antiplatelets, and the situation is going to be mess. And so take your judgment based on what you see on angiography. Case number 2, 70-year-old female with hypertension, diabetes needs hepatobiliary surgery. Again, a major surgery. She has severe bilateral knee pain limiting her activity. TKR has been advised on both sides. No prior major medical problem. ECG and echo are normal. and creatinine is 1.8 milligram per cent. Now, diabetes and hypertension, creatinine 1.8, this patient certainly needs risk stratification before major surgery. Now, you cannot tell the surgeon to just go ahead and go with surgery. Angiography and CT are going to be a problem with creatinine of 1.8. So here, in this situation, I would certainly advise a functional study like dobutamine echo or perfusion scan, and look at the extent of ischemia. I mean, just don't get carried away by some kind of a small area of ischemia in inferior lateral segment at high workload. Don't worry about it. But if you see something massive, something in multiple territories, left ventricle getting dilated, increased pulmonary uptake of the radiotracer indicating increased wedge pressure during activity, then in that situation, there may be a condition, there may be an indication to look for something beyond only functional study. And this last case, 59-year-old male, hypertension and TIA 6 months ago, has to undergo elective cholecystectomy. He has atypical chest pain on heavy exertion. ECG, echo, and lab investigation are normal. He is on ramipril, atorvastatin, and aspirin. Now, there are a number of choices, but this surgery of elective cholecystectomy is, I would say it's not a super major surgery. A patient has atypical chest pain, so you might want to assess his functional status by your good history, or maybe using a questionnaire. If he's able to walk for more than 4 minutes or activity for more than 4 minutes, you can clear him for surgery. And here, I would hesitate to stop his aspirin because he had TIA and he's diabetic. So he's not diabetic, sorry, but he has TIA. So I would talk to the surgeon, and if the surgeon feels comfortable on operating on aspirin small dose, which many surgeons do, he can operate on while on aspirin. So in conclusions, your aim of perioperative evaluation is to quantify the risk and minimize the risk. No testing unless it is going to change your management. Acute cardiac conditions need to be treated before surgery unless it is an emergency. Assessment of functional capacity is crucial, and I told you the magic number, that is 4 minutes. Coronary revasc does not reduce perioperative cardiac events. It should be performed only if independently indicated. On few occasions, the answers may not be in black and white. Discussion about treatment options and its risk-benefit should be discussed with the surgeon, anesthesiologist, and patient's family before taking final decision. So thank you very much for your patient hearing. We can discuss if there are any questions.
Yeah, thank you, Ajit. As usual, for a wonderful talk, a very elaborate one on a topic which is also close to my heart. You really nailed it when you said that fitness is a wrong word to use, and all of us should remember that we should never use that word. Normally, all you're doing is risk evaluation. So what I write is, may proceed with whatever surgery under suitable anesthesia. So anesthesia, we need not tell what anesthesia is to be used, with either a low risk, significant risk, or a very high risk, which is carrying, the patient carries with them. So no use of fitness. So you said it right. And normally we don't do that. Most of the people use fitness, that he is fit for surgery, but we should never really do that. Practically speaking, more often than not, patient is referred to us for so-called fitness only a few hours before surgery, because the surgeon has already admitted the patient and decided about surgery, and then suddenly just on paper they say that. So that practice also should be avoided, prevented. And like Western countries, we should have pre-op OPDs run by anesthetists or clinicians a day prior, and then only surgical date should be given by surgeon. In last 30 years, I can say that I know only 2 surgeons who used to send or still sending patients for evaluation, and then only they give appointment or date for surgery. So that, I think, practice has to be emphasized upon. Another thing is abuse or overuse of echo. And as you also said that most of our patients undergo echo when it is not necessary. If you look at the algorithm, the one that you have shown, there is a beautiful ACCHA 2014 algorithm which tells us that echo should be restricted to a very few selected patients. It comes very low down in the algorithm. And many times we get calls for doing echoes at night when the surgery is at 8 a.m. in the morning, which is absolutely unnecessary. I think the topic is open for discussion now.
I think
Anyone from faculty and comments?
Yeah.
Ajit?
Points mentioned by Shirish are very, very important. Sometimes, one of our surgeons, this is not a joke, but he has actually said this, that, referring the patient on the day of surgery and asking for fitness for 45 minutes. I want fitness for only 45 minutes myself. So, that is the mindset of, particularly ortho surgeons have that mindset. So, they are a different species. But at the same time, I think, what Shirish has correctly said, that it's risk stratification. And many times what I write is, even if the risk is, patient has very, very low risk of surgery. But generally what I write is, patient can undergo surgery under suitable anesthesia at average perioperative risk. There is always an average risk for everything. There is an average risk for even taking an injection, an intramuscular injection. So there is nothing like zero risk. You can always put it on paper, and it will always help you just in case the matter goes to court for some reason.
Dr. Bhagwat, so many times we come across patients in queries by surgeons that what is the preoperative risk, especially in elderly diabetic. For example, if you have an elderly lady, diabetic, obese, going for knee replacement with normal ECG, with some changes, STD changes on ECG and a normal echo, how often do you use dobutamine stress echo or CT angio in this situation to demonstrate the risk?
Yeah, I mean, this has to be, very, very case specific, and very, very, it has to be individualized for every case. But, broadly, from whatever you ask me, is an obese patient with some non-specific changes going for TKR, and you cannot, there is no way you can assess the functional status of the patient. In that, in that situation, if the patient has, say, risk factors like diabetes, hypertension, had a previous TIA, or was admitted for some reason in a hospital, some query condition that we don't know about. If you are not very sure about patient's past medical history and functional status, then I make it a point to, we don't do dobutamine echo in our hospital. Unfortunately, I don't do it. We don't have facility, but we do. We have an excellent nuclear lab. So we send patients for perfusion scan in this situation to risk stratify. Coronary CT angio also is a very good test, provided patient's renal function is very normal and patient is not obese. Because if patient is obese, the radiologist will call you and say that, this is an obese patient, the picture quality may not be good or whatever. So use it in in a very individualized fashion. It's not like all or none in this situation. But many times, let me tell you that we have recommended, send patient directly for surgery without much investigation, even if the patient is obese. If the patient no diabetes, no hypertension, no past medical history whatsoever, not on many medicines, can send the patient to surgery. And orthopedic surgery generally is considered to be moderate or low risk surgeries. If you really look at the list of high risk surgeries, orthopedic surgeries are not high risk surgeries.
So yeah, but for most orthopedic surgeries, I do use myocardial perfusion imaging a lot rather than relying on the dobutamine echo, which I find very subjective.
So there is a question from the audience.
More objective. Yeah.
Right, so one question so there is one question from the audience. Dr. Ravi Kalra, who is head of department at Bharati Medical College, he has asked, what about severe PAH patient and patients with cyanotic?
Yeah, I mean, very important questions. Cyanotic heart disease in a PH situation, in a pulmonary hypertension situation, is contraindication. I mean, generally you just, unless it's some life or death situation where patient is going to die anyway, it's a different matter. But Eisenmenger's is contraindication for surgery. That is one. In a situation where patient has cyanosis because of a RPS situation, a pulmonary stenosis situation, RVUT obstruction, cases can be individualized. When we have seen patients who have tetralogy of Fallot, undergoing surgery. I mean, it's not a contraindication, but the risk is high. And again, it depends on what surgery you are talking about. If you are talking about hernia surgery, a small inguinal hernia in a tetralogy of Fallot patients, you are going to say, no, don't get operated. It's not going to harm you. Just keep watching this hernia for every 6 months or every 3 months or whatever. But if push comes to shove, if the surgery is going to be something which can result in a catastrophe, this patient has an ischemic limb, acute ischemia of the limb, which is not proceeded to gangrene yet. Patient has to be operated. I mean, there is no choice, and you have to talk to the anesthesiologist, surgeon, and the family that patient has a bad heart disease. We'll take maximum precautions. We'll do our best and do the surgery. I mean, there are everything is very relative. It depends on the situation which you are facing.
For the sake of time, maybe a last question if somebody has a question. Otherwise, we'll wrap up. Thank you very much, Ajit, for a wonderful talk again. And we can move over to the next talk.
Thank you. Thank you very much. I will leave this.
Thank you, sir. Thank you.
Okay. Yeah.
So let's move on.
I have already... I'm not sharing the screen. Okay, yeah.
So let's move on to the second talk. We have the second talk on lipid goals in 2022. And we have a renowned cardiologist from India, Dr. JPS Sahni. He's a senior consultant cardiologist and chairman of cardiology at Sir Gangaram Hospital and has an experience of almost 40 years in the field of cardiology. To his merit, he had been awarded with 6 gold medals during his academic career. And in last 40 years of his practice, he has been awarded and honored with multiple awards: Silver Jubilee Award in 2001, Venkatrao Oration Award in 2004, Rashtriya Ratna Award in 2004, Vasisht Award in 2016, Times Healthcare Achievers Award in 2018, and many more. I welcome Dr. Sahni to present his talk, and I would also like to invite Professor Dr. N.G. Karindikar to moderate this session. He is one of the senior interventional cardiologists from Pune with 35 plus years in interventional cardiology. He was also awarded with gold medal during his DM, and he was due to his academic career. He has been recently awarded with Professor Emeritus at BJ Medical College and Sassoon General Hospital, Pune. He has many publications and chapters to his merit. I welcome him to moderate the session and hand over proceedings to him. Welcome, sir.
Thank you very much, Dr. Rahul Patil and Dr. Rajiv Sethi. At the outset, let me congratulate you. Great job you're doing, getting such eminent speakers year after year and in every event of our CSI Pune chapter. Now, as far as today's topic is concerned, I would like to say that atherosclerotic cardiovascular disease, or ASCVD, is the leading cause of morbidity and mortality all over the world. And modulation of lipids forms the most important tool in the cardiologist and the physician's armamentarium. Now, therefore, the importance of this topic, and I would just like to mention 2 very recent references. The RSSDI, Consensus Recommendations for Dyslipidemia Management in Diabetes mellitus, which was published just a few weeks back, maybe 2 or 3 weeks back, and of which one of the co-authors is our esteemed speaker today, JPS Sahni. Congratulations to you, Dr. Sahni, for being a co-author of this important paper. And one of the main things this paper brings out is that we have to move out of the shackles when we order a lipid profile, total cholesterol, LDL, HDL, triglycerides. And that's what we are many times satisfied with. But beyond this, there is a lot more. I would just like to quote one little sentence. lipoprotein B is considered as enhanced estimate of an individual's exposure to atherosclerotic lipoproteins, and is considered as enhanced estimate of an individual's exposure to atherosclerotic lipoproteins. I said that, and may be predominantly valuable for assessment of risk in individuals where LDL-C measurement underestimates the risk. And therefore, I would like to point out that estimation of this lipoprotein is very, very important. Similarly, LPA, triglyceride-rich remnants, small dense LDL are also very, very important. Hello, can you hear me? I think, am I audible?
Yes, yes, you are.
Okay, because somehow the video has, okay, it is there. Another very exciting reference which I came across in recently held American College of Cardiology conference in Washington just this month, 2nd to 4th of April, and a very exciting paper was read out. A single ascending dose study of an siRNA, that is small interfering RNA, targeting lipoprotein A, and it is unbelievable really, but quite true that this paper showed that subcutaneous injection of siRNA lowered LPA up to 98%, which is fantastic. And I'm sure Dr. Sahni will highlight all these points. Not only we have to investigate these patients better, we have to treat these patients better with the newer and newer drugs and modalities that are available. I would now like to invite Dr. Sahni, an eminent speaker. I think he has come up previously also, and I remember having chaired the session where he was the speaker. I invite him to start his talk. Dr. Sahni, please.
Yes, can you hear me? Yes, thank you, Dr. Neelkanth. Thank you, Dr. Rajiv Sethi, Dr. Rohit, and the CSI Pune for giving me this opportunity to discuss with you today's topic, lipid goals in 2022. I will be touching upon the dyslipidemia, as you know, about the final common pathway for most of the risk factors, the role of statin and non-statin drugs, the ESC guidelines for LDL, non-HDL through the triglyceride or remnant cholesterol, and finally genetic about the guidelines goals for the FH and lipoprotein little a. As we all know about that, the intra-heart study that the lipids are the most powerful risk factor for cardiovascular disease. And we know that the LDL along with the remnant cholesterol, or what we say non-HDL or ApoB, plays a major role. They enter into the formation of atheroma, and the risk factor like blood pressure, diabetes, smoking, and various other risk factors, they push that LDL. So this is the final common pathway of starting the atherosclerosis. And we have also have now good data that effect of LDL by magnitude and duration of exposure coming from the Mendelian randomization study of more than 50 years, prospective cohort study of more than 12 to 14 years, and randomized clinical trials. They have shown that the LDL concentration is strongly and log linearly associated with dose-dependent increase in the risk of incident atherosclerotic cardiovascular disease. And the management in both primary and secondary prevention trials with using statin in moderate to high doses have shown that if you reduce LDL cholesterol down below 70 or 50, there is a reduction of cardiovascular events. And this has been the meta-analysis of the trials of more than 90,000 patients have shown that if you reduce 1 millimole, that is 39 milligram of LDL over 5 years, there is 23% reduction of major coronary events and major vascular events. We have also learned that for acute coronary syndrome, the benefits comes much earlier, but for primary prevention and chronic coronary syndrome population, it generally takes more than 1 year to get the benefit. Within 1 year, only 10% benefit, but after 1 year, definitely we get around 20 to 22% benefits, and that keeps on having increase in the benefit of lowering the LDL cholesterol. So what we learned was that the high cholesterol, average cholesterol, and bringing down to less than 70 was with the high intensity statin have shown reduction of cardiovascular events. And then came the story about the non-statin drugs, because when we have a limitation that we can't go beyond that, the non-statin drugs like the HTMI in Emcure trial and PCSK9 inhibitors in 4-year Odyssey trial have shown that if you reduce it further, there's a further reduction of cardiovascular event by around 10 to 15%. And so this slide shows that whichever method you apply, reduce the LDL cholesterol, whether by statin or one non-statin drug, both are showing equal benefits. So there's almost 22% by statin and almost 21% by non-statin drugs. So that do not make any difference, but both drugs are effective, and combining two may be a better way of managing this lipidemia. This is the study about the HTMI in the Emcure trial. All of you know about that acute coronary syndrome, high dose of moderate to high dose of statin along with HTMI versus placebo. The average cholesterol was around 70, and it has been brought down to less than 55, on average 53, and we found reduction of cardiovascular events. And the benefits were much more in diabetic population compared to non-diabetic population. Probably there is some data not accepted by all, that the absorption of cholesterol from the diet in diabetic is slightly more than non-diabetic population. Probably that's the reason why the HTMI probably has shown a more beneficial effect. And then we know about PCSK9 inhibitors, which are injectable drugs, subcutaneous injection, 140 milligram twice a month. And this has shown that the drug acts on the PCSK9 protein. We know that the LDL receptors over the hepatocytes, they bring down the LDL levels by the LDL particles get attached to the LDL receptor. By endocytosis, they are secreted out. PCSK9 protein secreted in the hepatocyte gets attached to the LDL receptor and causes their degradation, and they do not allow them to come to the surface of hepatocyte. So if you use monoclonal antibodies using either Rocamab or Lebrikizumab, we have found that they get attached to the PCSK9 and do not allow their degradation of the receptors. So more receptors are available on the surface to reduce the LDL cholesterol levels. They not only reduce the LDL cholesterol, but also significantly non-HDL ApoB by around 50 to 55%. But that important finding which was observed was that Dr. Nilkant has said that the LPA was also reduced by 25 to 30%, which is now emerging as a very important component of management of dyslipidemia in clinical practice. So this was a study which was done in chronic coronary syndrome patient, 27,000 patients on high dose of statin with or without HTMI, having LDL more than 70, given Emcure compared to placebo, bringing down the LDL to below 30 on average, and reduction of primary endpoint and secondary endpoint was observed. The drug was effective and safe. And they found that even going down below up to 20 milligram of LDL cholesterol was possible. And the most important thing was that it is safe. Even going below 20, looking at the different quartiles from 100 to 20, every patient, they do not have increase in side effect of new onset of diabetes or any cataract or transaminitis or myositis. They were very well tolerated in this patient. The other study which came was the Odyssey trial in acute coronary syndrome, almost 19,000 patients using another PCSK9, Lebrikizumab, bringing it down to less than 40 compared to placebo. Again, they found that the primary efficacy endpoint of MACE and all-cause mortality was reduced. You can see here in this, the curves only start widening after 1 year, as I've just showed that it takes little time for the anti-lipidomic drugs to be effective in terms of reduction of MACE. So with this two drugs, the data was very clear that if you go below the 70, even the lowest is the best. So based on this data from the clinical trials of statin or non-statin drugs, the ESC guideline came on 2019, and they came out with the new recommendation of LDL goal. So they said every patient should be risk stratified. So they said the very high risk group of patients are 5 groups. The one is which was suffering from atherosclerotic cardiovascular disease, any patient with the stroke, even aneurysm, TIA, peripheral vascular disease, the first group, and second, in same group, they found that if you have imaging evidence of more than 2 major epicardial artery, like in CT angiogram, which is very common, a popular investigation this day in clinical practice, and they found that if it is there in more than 50% of patients, this is also belong to very high risk. Diabetic patient with more than 3 major risk factors, or diabetes more than 20 years of duration, again comes under very high risk. Severe CKD with atherosclerotic cardiovascular risk score of more than 10%, familial hypercholesterolemia with atherosclerotic cardiovascular disease. All 5 group of patients, they belong to very high risk group patient, and they have to keep their LDL below 55 milligram or at least 50% reduction from the baseline. But if a patient who has recurrent events within 2 years, then they have suggested to keep it below 40 milligram with the level of evidence only class 2B recommendation. The second group is, which is more common in clinical practice also, now is a high risk group, primary prevention group, which I say, if LDL is more than 190, or they have included very interesting point now is BPA more than 180 by 110. As an independent single risk factor, they have considered them as a high risk patient. Patient of familial hypercholesterolemia without CVD, diabetes, without target organ damage, but at least risk factors, and additional risk factors, moderate CKD between 30 to 60 ml GFR, they have been belonged to the high risk group, and they have suggested to keep it less than 70. So based on this, it looks like that most of the diabetic population, generally they have associated one risk factor, and the average diabetic population probably will be requiring to keep the LDL to less than 70. Regarding the hypertension part, probably in future, probably we are now getting some evidence that like diabetes, majority of them, we should keep it below 70, because if you got any risk factor, keeping below 70 LDL is a good method to reduce the future atherosclerosis. Probably in future, not all the hypertension of such degree, but probably every hypertensive with the control, even with control of blood pressure, they may be requiring to keep the LDL below 70. Moderate risk is generally diabetic patient with a short duration without risk factors. Again, a group which is seen in younger population, probably to keep it below 100 may be a good idea to do that. They have also suggested in the guideline now that acute coronary syndrome patients, which we see in our country now, that most of the institutions do not do a lipid profile. They do every blood test, but lipid profile is not done with the view that anyway we have to give statin Y to get the lipid, which is the wrong practice going on. So it should be done in non-fasting state. Anytime patient gets admitted in the hospital, you should get, along with the other blood test and non-fasting lipid profile, for 2 important reasons. One is that it will give you an idea that this is playing an important risk factor for getting this coronary artery disease. And second, it gives you an idea of how high they are, whether should we start only with statin or we have to add combination treatment in the beginning. So this is very important. So guidelines have suggested that step 1 will be to give high dose of statin, wait for 4 to 6 weeks. If the levels are not below 55, add ezetimibe, wait for another 4 to 6 weeks, and then only add PCSK9 inhibitor. But with this practice, what we found, the recent Da Vinci study, of course, this is a real life study where most of the patients were not given high doses of statin. A few of them were also on modest doses of statin. They found in real-time clinical practice less than 20% of patients are achieving less than 55. But yes, if those who are receiving high doses along with ezetimibe, more than 70% could able to achieve. And we have done a small study in our hospital, smaller number is going on study, and we found that only single high dose statin, either 80 atorva or 40 rosuvastatin, we could able to achieve less than 55 milligram in more than 80% of patients. And the guideline also suggested that if you use only high dose statin, roughly you reduce LDL by 50%. But if you add ezetimibe and as high dose statin, you reduce by 65%. If you add all the 3 drugs, probably 85% reduction of the LDL is achievable. Recently completed ES study where all the lipidologists, they have suggestion now that instead in step 1 should be merged in hypertensive statin with ezetimibe to those group of patients, those who come with acute coronary syndrome in the hospital and their LDL is more than 110 or 120. We know that alone a high dose of statin will only reduce by 50%. From 120, it will come to maximum 60, which is not the goal which is desired. And for that, they suggested to start with ezetimibe in high dose statin in this population as step 1. This will give you an idea that it will omit one's first step and merge 2 steps, and then add PCSK9 after 1 month. So that instead of waiting for 3 months to achieve the goal in few number of patients, probably will able to achieve it within 1.5 to 2 months time, and thereby reducing the future cardiovascular events which are high in ACS population. So they have suggested that 3 step should be merged to 2 in such high risk, very high risk population, those who are baseline LDL cholesterol is higher than 120 milligram. A significant number of patients, they also do not tolerate statin And for them, as I said, some of the patients, they are unable to afford PCSK9 inhibitor, and they are unable to reach the goal. This bempedoic acid is now coming up our country. This is now already available in European country and USA. It's a drug which is a pro-drug, has to be activated in the liver. It works a little step ahead of HMG-CoA reduction, and the enzyme ACSV activate the drug to the to product, and which start acting. Fortunately, this enzyme which activates the drug is not present in skeletal muscle. That's why this drug is exempted from the side effect of myalgia. And this drug has been studied clinically now. Three important phase 4 trials have shown that alone drug on statin, it reduces by 18%, but if you give it alone, it reduces by almost 25% LDL, much more than that of HTMI alone, which is around 15%. And the combination drug is also available in the market, where they have shown that if you combine them over statin, then it is 36%. But if you use them alone, then along with statin, that goes even up to 45% reduction. The good news about this drug is important to learn. One is that it increases uric acid and should be avoided in patients with gout. It significantly increases uric acid level. The good news is that unlike statin, which increases the diabetes, new onset of diabetes drug, this drug works other way around. So these studies of the pool studies from the clinical trial have shown that it reduces HbA1c and reduces fasting sugar levels. So it is behaving in a just opposite to the statin. The clear outcome trial on 14,000 patients is ongoing, and I think end of this year we'll get the endpoint of this trial, looking at the cardiovascular endpoint. So what we have learned that this drug is inhibitor of ATP citrate lyase acne, which inhibits hepatic cholesterol synthesis upstream of statins. A pro-drug activated by ACSVL, not present in skeletal muscle, so there is no myalgia as a side effect with this drug. Drug, as I said, is powerful, 25% reduction. Along with statin, 45% reduction, along with HTMI, 3 drugs, very well tolerated in most of the statin intolerant population. And they have shown that it improves the glucose tolerance, and 25% reduction at HSCRP has been seen with this drug. The incretin, as Dr. Neelkant was saying about that drug, a small interfering double-stranded RNA drug, being studied in Orient program at the moment by Dr. It inhibits the production of PCSK9 specifically, durably, and potently. 300 milligram twice a year. Incretin lowers LDL by around 50%. It's very effective, safe, and well tolerated. FDA has approved this drug now. Dr. Kaushik Ray has worked on this study, and Orient 4 trial is going on at the moment on 15,000 patients. Probably next year we'll get the result for the endpoints. But the drug is very effective, and very, very important thing is that it will improve the adherence therapy and maybe a challenge to PCSK9 inhibitor. Well, having discussed about the goal of the LDL so non-HDL, what is coming up now is because we cannot ignore the hypertriglyceridemia. And the drug treatment for that, the guidelines have suggested now if the LDL, the triglyceride is more than 200, just keep on increasing the dose of statin. Maybe you can add HTMI up to 500 milligram triglyceride. So what we have learned that there is a residual risk, as we've said, that with high dose of statin that persists, but then we have to now target the various factors which are accounted for the residual risk. And as I said, high cholesterol, we have now learned by adding the HTMI and non-statin drugs like PCSK9 inhibitor, and in future with inclisiran and bempedoic acid, we'll able to reduce the LDL further lowered in high-risk population. Inflammatory risk has been now trusted in Contour's trial and Dodocort trial. We have used the small dose of colchicine as an inflammatory agent. For thrombotic, we have learned about the Campus trial using the rivaroxaban. And finally, 2 important factors from the lipid metabolism is the residual triglyceride, which I'm going to discuss in more detail, and LPA also I will be touching that above 50 milligram per deciliter is also very important residual risk in this population. And of course, diabetic population, SGLT2 inhibitor is playing, and GLP-1 has played a very important role, as we all are aware of. In the real time, the study from the Copenhagen, and there's almost 2 lakh population, real world risk of cardiovascular outcome associated with hypertriglyceridemia among individuals with atherosclerotic cardiovascular disease. they have found that patients, those who have already achieved LDL goal, they are still approximately quarter of them, they have very high triglyceride. I think in our country, because of metabolic syndrome, I believe this figure may be touching almost 50%. So they have shown very beautifully that as the triglyceride level goes above up to 400 to 500 milligrams, there is a constant increase in the atherosclerotic cardiovascular disease. So the cholesterol component or remnant cholesterol present in triglyceride plays a major role. And what we have seen that with the triglyceride levels are high, the LDL particles become smaller. And what we can see, in B48 nanomicron small size, the IDL, the VLDL cholesterol component of the VLDL, all combined together, they initiate the pathogenesis of foam cell formation and macrophages. So we have learned that these are the various mechanisms by which the hypertriglyceridemia causes atherosclerosis, along with the low HDL cholesterol, which is always a part of the high triglycerides. And besides the triglyceride also has a procoagulant stage. Increase in PI1 has been seen in high triglyceride population. And for that reason, guidelines are suggested to use non-HDL cholesterol, which is total cholesterol minus HDL. And recent, the SCORE2 guidelines, which have come from preventive cardiology in Europe, they have taken non-HDL rather than LDL cholesterol as a marker to risk score. And remnant cholesterol can be also estimated, which is nothing but the total cholesterol minus LDL and minus HDL cholesterol, which becomes the remnant cholesterol. And the remnant cholesterol has a very important volume. There's a very good paper published in JACC recently. They have shown that VLD lipoprotein, the blue one is the triglyceride part, which has got no role in the pathogenesis of atherosclerosis, whereas the yellow part, which is the cholesterol, VLDL cholesterol, IDL cholesterol, and LDL cholesterol, they enter into the intima and forms the atheroma. And if you look at the VLDL particle, they directly enter into the atheroma, whereas the LDL has to be oxidized before it enters into the formation of atherosclerosis. So that shows that the remnant cholesterol plays a major role also in the process of, and that's the importance of non-HDL cholesterol in clinical practice. And to address that, how to manage besides statin, the role of fenofibrate has been studied and found not very effective. The reduced trial, all of you know that, where we have used EPA 4 gram versus placebo, and both primary prevention and secondary prevention by population have shown a reduction of primary endpoint by 25% and secondary endpoint by almost 26%. Similar study done in Japan a few years ago, looking for both primary and secondary prevention, but they used 2 grams instead of 4 grams because probably Japanese have high EPA level in their blood because of high consumption of fish. And they have found similar type of benefit in reduction of cardiovascular events for both primary and secondary population. And this is what the JALIS trial, you can see for both the studies over a period of 5 years, 19 and 18% reduction of major cardiovascular events. Based on this, coming to the hypertriglyceridemia, the goal of triglycerides have been now divided into 2 groups. One is less than 500, above 150 to 200. They have suggested to first to go for lifestyle modification and the exercise, weight reduction, avoid alcohol, smoking, reduce carbohydrate food, and then keep on adding the statin drug and keep on reducing the LDL and non-HDL cholesterol. Target non-HDL. It is not simple that you have to add LDL 30 milligram. Sometimes we have seen patients who have achieved LDL, but non-HDL is quite far off. You have to increase the doses of statin in this population. The role of fenofibrate has not been suggested. Only in this group of population, they are suggested to add the EPA to 4 grams per day along with the statin drugs. This group is basically to prevent the atherosclerosis. The patient, those who are TG above 500 to 1000 probably, which is more prone for pancreatitis, and above 1000 are definitely they increase significant pancreatitis. They do not cause atherosclerosis. Again, lifestyle modification plays a major role, but here the fenofibrates have a role to play, and then we can add the omega-3 fatty acids, the EPA, and along with statin probably we'll be able to do. But there are a group of patients, probably those who got very, very high triglycerides in thousands, and the olnaceron is probably a drug which is now not available, but it is being tested in phase 3 trial, found to be very effective in reducing triglyceride by 80%. Coming to another question which comes is, the lowering is good, but not, how long is good, but problem is how long to continue. So this data has come from the what we have learned from the randomized clinical trial, that in randomized clinical trial over a period of 5 years, you reduce LDL by 80 milligram, but the cardiovascular events is reduced by only 30 to 40%. If you look at the genetic studies where they have found Mendelians like loss of function of PCSK9, there you reduce LDL by only 40 milligram, like instead of 120, what is the average LDL of American, it becomes 80 milligram in those population, those who are genetically determined. There we found that over a lifetime risk of reduction of cardiovascular event is 80%, double of that what we see in clinical trial. Even we are reducing LDL by double. So that shows that it is the lifetime exposure of LDL which is important. So earlier the better is good, but to reduce the lifetime risk, longer the better is good. Coming to my final part of talk is genetic dyslipidemia. The lipoprotein, all of you are aware, and Dr. Ilkant has just discussed. It has not only a two moiety, LDL cholesterol and ApoA, which is a procoagulant and more atherogenic and can cause more lethal complications. And this has been now guidelines have suggested that in life, each adult should have at least once their lipoprotein estimated. Above 180 is just equal to FH. And for premature family history, for reclassification of patient, probably LPA is a very good moiety. And we have also learned that statins have resistance to reduce the, statins do not change the LPA. And many patients with high cholesterol, if they are not showing a predicted reduction of LDL cholesterol, like 50% reduction with high dose of statin, we start thinking that probably patient has got high lipoprotein A because they are generally resistant to statin treatment. And the meta-analysis of the clinical trials, Mendelian randomization and genome-wide association have clearly shown that if there was around above 50 milligram of the LDL, there is an increase in cardiovascular events. And the drugs treatment, as I said, so far available is the PCSK9 inhibitor and Fourier trial, and now subgroup study from the Odyssey trial have shown that if the LDL, if you use this group of drug, when they compared patient with the LPA less than median level, less than 50 and above 50, they found that those who were above 50, and if you use the PCSK9, there was reduction of LPA, and at the same time, there was more reduction of cardiovascular events. The drug was more effective in those population, those who got not only high LDL, but also high lipoprotein. So they're showing for the first time that lowering LPA also works in reducing the cardiovascular events. The familial hypercholesterolemia, or if you know that, not that rare, which we thought once it is grossly underdiagnosed and undertreated. Homozygous is rare, but the heterozygous is quite common. 1 in 250 increases a very high level of cholesterol up to 200 to 50. And they cause the premature atherosclerosis in 4th and 5th decade. Receptors were identified by Dr. Brown and Goldstein and got Nobel Prize for that. And then we know that the various methods of diagnosis clinically, and we found Dutch Lipid Clinical Network, and which is now endorsed by even the International Family Hypercholesterolemia Registry, which is going on. The majority of the people, they use this simple criteria. It's simple that we look for the young coronary artery disease patient, if less than 55 men, less than 60 women, then we have 2 points, and similar type of history looking into the premature CAD and the peripheral disease, you get 1 point. Look at LDL cholesterol above 150 to 190, you get 1, but above 190, you get 3 points. And arcus cornealis, a type of semicircular grayish deposits on the cornea, more commonly seen upper part of cornea, you get straight away 4 points. Of course, the gold standard is the DNA analysis, or what we say genetic testing, looking at LDLR, ApoB, and PCSK9, which you get scored straight away 8 points. But if you clinically get point above 6, which is basically probable and definite FH group, they are now called as the potential FH group. They have been validated with genetic studies and found to be very, very good validation with them. And they have found that they are very easy to diagnose clinically. And guidelines have suggested to suspect in every young patient, keep the LDL below 17 patient without CVD, but if there is CVD, then keep it below 55. And majority of the patient, because they have very high cholesterol, they need HMI or PCSK9 inhibitor. But besides that, the family's cascade screening is very important, because it is an important part of the management of the FH population. A simple non-fasting lipid profile for the children, a sibling should be done. LDL more than 150 for children and 160 for adult probably gives you suspicion that patient is suffering from is a genetic carrier. So by diagnosing a case of FH, we do not identify a case, but a family at risk. Starting statin very early in stage probably will help to reduce the future evidence. So that is very important that we can start as early as possible in carrier group of population. We have published our paper in India Journal and long ago, 3-4 years ago, with 15% incidence in young population. Now the papers, we are accumulating the data on 1,200 patients and found it is 17%. The definite and probable combined together, what we say PH, the potential FH population. And what we learned very interesting, that only these people, those who are definite and probable FH, they have more high cholesterol level, but other risk factors are less. So if one should suspect FH in young CAD patient who has got elevated LDL and without risk factors, or got less number of risk factors, one should always look for that and you will be able to find it. So in conclusion, dear friends, what we want to say that probably in future, the management of lipid with the different goals for the LDL or non-HDL or even for triglyceride, it has to be individualized combination treatment. Lifestyle modification, statin is the mainstay of the treatment. But the patient, those who got SAMs, the side effect of statin, probably ezetimibe or bempedoic acid or maybe PCSK9 inhibitor can be used. And the patient, those who are unable to reach the goal of LDL as for example, 55, again, these three drugs are very useful to be combined with statin, or if they cannot use statin at all, then alone this drug, ezetimibe, bempedoic acid, and PCSK9, and future inclisiran will able to achieve the goal of LDL cholesterol. Coming to lipoprotein A, as Dr. Neelkanth was just discussing, this is a drug pelacarsen, which is now available, which reduces almost 80% LPA and against 25 to 30% by the PCSK9 inhibitor. High TG population with high ApoB or non-HDL cholesterol, adding along with statin and lifestyle, probably a high dose of EPA is good. And now Ensplat 3-AS or evinacumab is being tested for that, and probably in future we'll have that drug also. The bad HDL, probably we have not much a role to play. So what to conclude my talk, that dyslipidemia is the most powerful risk factor. LDL is common, easy, and simple tool to monitor. However, the best marker for atherosclerosis is non-HDL, which includes remnant cholesterol and more useful in high triglyceride population. Guidelines have suggested to keep LDL less than 55. So high-intensity lipid lowering therapy is the most effective way to control lipid. So combination of high-intensity treatment with ezetimibe as an initial treatment, followed by PCSK9, may be required in significant number of population. So in the end, I will say the new managed lipid profile, earlier the better, lower the better, longer the better, together the better. Thank you very much.
Excellent talk, Dr. Sahani. And you have really comprehensively covered every aspect of lipid goals in 2022. And you have also mentioned your pioneering work in familial hypercholesterolemia, the landmark work that you have done. Congratulations. I would like to ask a question. Before that, I would just like to say, I was just listening to one of Dr. Ashok Seth's talk, and he mentioned that some cardiologist patient sued him because after angioplasty, he had not brought his lipids down to the target levels, and he won the case. That is a story which he told. And one of the recommendations is that before angioplasty and after PTCA, PCSK9 inhibitors are recommended. And I would like to ask you that, do you practice this? And if at all you do, then for how long?
You see, yes, you're right. See, then the guidelines have also given recommendation of class 2A now. If a patient has come to with acute coronary syndrome, is already on statin and ezetimibe, and his levels are not achieved, then giving PCSK9 inhibitor in this hospitalization of acute coronary syndrome is now recommended. And it causes not only the effective reduction, but very rapid reduction of LDL cholesterol. Yes, we are using this drug in some situation, although this situation is rare. Because we found in our study that most of the patients are able to achieve the LDL below 55 by only high dose of statin. I have added ezetimibe now, started adding to all my patients, those who got the baseline LDL of more than 120 or 130. They're starting combination treatment in the beginning probably is a good method to achieve the targets earlier.
So if the LDL target is already achieved with statin and ezetimibe, then you will not start
No.
PCSK9.
No.
Yeah. Okay, that
No.
looks very reasonable. Yes, yes. MS.
Dr. Shirish,
Thank you,
asking them.
Dr. MS here.
Yes, sir.
You know, most of the time the lipid profile was done during 40 up checks. I mean, there are many industries in Pune who have this regular health check starting at 40. I think that age should be lowered and we should start taking lipids much earlier, or what do you do in your clinical practice? Like,
Yes,
say,
I always say although the initial recommendation of ATP used to come few years ago, they say at the age of 20, one should know their lipid profile. If a person knows his blood pressure, knows his sugar, why not lipids? Because the sugar and blood pressure probably has got some symptom. Lipid has no symptom. So I think starting at very early age, as you rightly said, is very important. If the levels are normal, then we may repeat after 5 years. If the level are high, then we should repeat every yearly. Yes, but the patient with the family history of premature CAD, I think there we should start much earlier. And in my studies, which I've done for FH, I've done lipid profile for all my patients, children, and those who are at the age of 8 years. And now we have reduced the age to 5 to 6 years now. And we are getting a lipid profile at that stage. 3 months ago, I had a young patient of 38-year MI. His younger brother died at 36, father died at 44, and he had 38 MI. He has a daughter of 6 years, and her lipids were 239 LDL. And the mother asked me what to do. I said, we have to start statin, but we thought the recommendation starts with 8 years age. But she showed me now that we can start at 5 years. And this girl is now on 10 milligram of rosuvastatin. LDL is now below 100. But I think recommendation for children is to keep it below 135. So yes, I fully agree.
Yeah, I would also feel that if you can't find a family history of coronary events at a younger age, or hyperlipidemia in the family, I would still feel that young age with no known risk factors, like somebody who has grown in village, is 18, 20, comes to a city, a lipid profile, and his LDL is 130. I would clearly worry that because you know it's very difficult to trace the entire family, and I won't waste time in doing that and probably treat this gentleman in front of. Same with you, or what is your?
Yes, I think I fully agree, and I always argue with my some of the. We had a good meeting many times with USA, and they have accepted now that in many patients between 20s and 30s, they come to you with executive check, and a 30-year-old boy comes to me with a LDL which is 140. He has no family history. He has no risk factor, no diabetes, no blood pressure, nothing. Now, what he asked me, he says, I am doing best possible lifestyle modification, diet changes, whatever. You know, diet takes only 20% care of the LDL. Mainly it is lipids from the liver. So I think if we are treating hypertension at the age of 20, we are treating diabetes at the age of 20, why are we not treating this? So there is definitely a area where we do not have a definite answer at the moment. Nutraceuticals have been used like Chinese red yeast rice, certain other berberine, those who are prevent the absorption of cholesterol from the intestine. The Chinese red yeast rice works just like statin, and they reduce the cholesterol. But I have seen in some of my patients, when the pre-lipid drug was available, they used to complain of myalgia also as a side effect. Even we have given them this drug. The drug is not very effective. 10 to 15% reduction of LDL was seen with this nutraceutical group of drugs. But starting statin, probably I am in favor of that. I start my patients above the age of 30, 35. If they come with LDL, no other risk factor, no family history, I give them a small dose of statin, just like treating them for hypertension.
40 up checks should be now called 20 up checks.
Yeah, 20 abstracts. Yeah, great. What my friend says sometimes that the birthday, every birthday after the age of 20, one should go for lipid check. so, that should be the part of the celebration. So,
Dr. Sani, coming to patients with high triglycerides. Now you have a patient with dyslipidemia. You have given him high dose statins. You have achieved your LDL target. The triglyceride is still more than 200, 250. And what's your choice of the next drug? Is it fenofibrate or is it?
No fenofibrate. Fenofibrate not to be given till up to 500 milligram. Fenofibrate in reducing the cardiovascular events have not shown any benefit. Mild reduction of non-fatal myocardial infarction, but not more than that. No mortality reduction, nothing. None of the trial have shown. Whereas EPA, 4 gram or 2 gram in Japanese study have shown a reduction of cardiovascular events. So the guideline now say that such group of population where you have achieved non-HDL cholesterol also, I mean, you have reduced non-HDL cholesterol also to the target level, and still triglycerides are high, probably adding EPA will be the best way, not fenofibrate. Fenofibrate will be only given if it is more than 500 milligram of triglyceride. The recommendation is use fenofibrate, bring it down below 500. That will be then you repeat the lipid profile. That will be the ideal LDL you will be able to calculate, or direct LDL will be calculated. That is always better. Otherwise, the calculation of LDL becomes faulty if the triglyceride is more than 500 milligram or 400 milligram even. So fenofibrates unfortunately have been overprescribed in clinical practice. It should not be done. It doesn't give benefit, it causes more side effect.
What is your experience with saroglitazar? We have seen that it reduces triglycerides.
Yes, saroglitazar experience with me is good, particularly in diabetic population. And I have used now that drug in pre-diabetic population. I mean, those who are having HbA1c between 6 to 6.5, I am finding high triglyceride with them. And what to do for that? Saroglitazar not only reduces triglyceride, but also prevents the hyperglycemia. So it may help us in preventing the clinical diabetes also. So that area is not been tested or be under investigation at the moment, but the recommendation is so far only for diabetic dyslipidemia. If the diabetes is controlled, and in spite of that, the triglyceride levels are high, saroglitazar may be a good drug to be given because its side effects are very less compared to fenofibrate. And it's a good drug, a powerful drug. So my patient, those who are having more than 1,000, 2,000 triglyceride, what I do, I use fenofibrate, use saroglitazar. Already they have got fatty liver also. These days gastroenterologists are using this drug to reduce the NASH. I mean, they reduce the fatty liver, and then we can add the EPA. Now EPA is available in our country by the name Cosatil. And this is available. So we use EPA, fenofibrate, and saroglitazar, all three together. These patients are more than 1,000 triglyceride. I have found a very good control of at least below 300.
Do you think
those who are having, I have one recent patient of my colleague who has 14,000 triglyceride. These cannot be managed with this three drug. The lifestyle modification has to play a major role. Stop alcohol, go for regular walk, reduce sweets, reduce carbohydrate diet. All those things has to be played, reduce weight. But in spite of that is not. So Waldeserone drug, which is now being investigated, had found to be very, very effective in reducing the familial chylomicronemia syndrome, what we say FMS. This is a condition where the triglyceride levels are in thousands, 4,000, 5,000, like seen in clinic. Although rare, but we have seen such patients.
Do you think saroglitazar is being underutilized? And what is your triglyceride level threshold to start this drug?
Above 500.
So below 500, you will not use even saroglitazar.
Below 500, first I will, because below 500 triglyceride has a large component of remnant cholesterol playing a role. So that is fear of atherosclerosis. Above 500, fear of atherosclerosis is less because the chylomicron size is large. That cannot enter into the atheroma. But what they cause the blockage of the pancreatic blood vessels, and they can cause pancreatitis. A third common cause after gallstones and alcohol is the high triglyceride. And that is the mechanism because very high, large sizes of the chylomicron, they clog the vessels of the pancreas and causes pancreatitis. For that, we are not having any fear of atherosclerosis because that large particles cannot enter into the intima. So there we have a definite role of fenofibrate and saroglitazole. But in that, but so far the guidelines, what they have suggested, the recommendation from DCGI is only for diabetic dyslipidemia, those who have controlled diabetes, and in spite of that, their triglyceride levels are high, then use saroglitazole. I am finding him much stronger than fenofibrate.
Right. So I think we have
safer
a session, and we must thank Dr. J.P. Sani again for an excellent talk on the lipid goals. And it is always a pleasure to listen to him and so much to learn from his vast experience in lipidology. But for the sake of time, we need to move on. We have our special guest who has joined us from USA, Dr. Manish Patel. And he's going to be our next speaker. On behalf of CSI Pune, I extend a very warm welcome to Professor Manish Patel. He is a Richard Stack Distinguished Professor, Chief Division of Cardiology and Clinical Pharmacology and Core Faculty for Innovation and Entrepreneurship at the Duke University School of Medicine, Durham, North Carolina. He has previously served as Director of Cardiac Catheterization Laboratories for the Duke University and has been past chair of the American College of Cardiology Task Force for Appropriate Use of Cardiovascular Procedures and the AHA Diagnostic and Interventional Cath Committee. He has received the prestigious Duke Cardiology Fellowship Mentor Award in 2010 and has received the Robert Califf Faculty Clinical Research Award in 2013. He has been investigator in landmark clinical trials, including Rocket AF and in cardiac imaging. He is noted to be in the top 1% of cited researchers by Clarivate Analytics and has published over 300 peer-reviewed articles in high-impact journals and over 20 editorials in JACC, JAMA, NEJM, and so on. I welcome Dr. Manish Patel again and thank him for taking out time for this annual conference of CSI. The moderator for this talk is Dr. Sunil Sathe, who is a very senior interventional cardiologist and electrophysiologist of the city. In fact, he is the one who has started the EP program in the city of Pune. I now hand over to Dr. Sunil Sathe to kindly introduce Dr. Manish Patel. Thank you.
Thank you, Dr. Sethi. I think the next talk is extremely important. No-vaccine atrial fibrillation, pearls and myths. And I think this is an important topic in our day-to-day clinical practice. That's why it's important. And to enlighten us on this very important talk, we have Professor Manish Patel. He's an elegant speaker and an extremely good teacher. Over to you, Dr. Patel, for your talk on no-vaccine atrial fibrillation.
Yeah, thank you. And hopefully you all can hear me. I appreciate you all letting me join you from the CCU here at Duke. I know it's the evening time there, so hopefully you all are having a good meeting. It's an honor, and hopefully when the pandemic is better, we can meet in person and not have to have so many Zooms. I have a difficult task in that I have to try to teach you something that you've known for a long time. So the question is, what can I teach you new about atrial fibrillation? But I will try to use some talks and slides that you all have had, I suspect, for some time. But I will present and go through a few different slide decks to see pearls and myths with atrial fibrillation. There are many, and it's around DOACs and the use of anticoagulants. Some of you will know that I have presented recently at the American College of Cardiology factor 11 inhibitors, one that Bayer is using called asundexian compared to apixaban, to look at bleeding and eventually think of new therapeutic targets. These are my research grants and advisory boards, several pharmaceutical companies and the NIH at the United States, several trials that I've been part of, some of which are with atrial fibrillation, but several that are interventional or others. I don't think that's a pearl or a myth to understand how many people in the world have atrial fibrillation and that it is a growing prevalent problem. But maybe I would say, as I've said before in these conversations, is what changes the way we behave in, is it the rational data, the effect that we know? Is it practice of patients that you have? What could I present that could change and make us think of new targets? So I'm going to present a patient, and then I'm going to ask you to tell me what you think are the most important questions in managing the patient, and that might help me with the pearls and myths. 78-year-old lady with atrial fibrillation, hypertension, diabetes, and some peripheral artery disease with an ABI of 0.78, 0.82. She has neuropathy, is concerned with unsteadiness, and she has heart failure. Heart rate is 73. eGFR is 41, and she's on aspirin, older diabetic agent, metformin, amlodipine, Lipitor, multivitamin. And the question is, should she be on an oral anticoagulant? She's unsteady, and which DOAC should she be on? Common questions if you think about it. So today, you would treat her. Should you treat her? Would you treat her? And if you treated her, would you treat her with a Apixaban 2.5, a Apixaban 5, Riva, that's twice daily, Riva 15 or 20, Dabigatran 110, 150, left atrial appendage occlusion. I don't know how much of that you all are doing. So certainly she's not on dialysis, but she's unsteady. She may be felt to be a bleeding risk. I'll start with my pearls, myths, conclusions, and then I'll think about it using the dose and the dosing schedule that's been scheduled for patients with randomized controlled trials. Don't reduce the dose. The biggest, most common thing I see is a treatment algorithm in people who reduce the dose because they believe patients, this is the biggest myth, they bleed less with a lower dose. Now, why does that not work? Well, we'll talk about that in a second. Renal function and dosing schedules based on randomized trials, and then be wary of real world studies. I'll share some of those for you in a second. And those studies tell you to choose one therapy over the other. And I think there's a lot of unmeasured things that we have to be careful about. So these are the ESC guidelines from the practical guidelines. Does a patient have mitral valve, moderate mitral stenosis? No. If yes, then it should be vitamin K antagonist. And then estimate CHADS VAS score, 0, antiplatelet, 1, oral anticoagulant, 2, should be considered, or 2 or greater, barring contraindication, NOAC or DOAC versus vitamin K antagonist, or left atrial appendage closure. So that's not really very new. So the first myth or key learning is the risk evaluation for stroke versus bleeding. So the patient I presented, you see her in clinic. I don't have a way to poll the audience, but if I could, I would ask the audience to tell me, if you could measure one thing, would it be CHADS 2 score, CHADS 2 VAS, HAS-BLED, hemoglobin, or creatinine? I just showed you the guidelines say CHADS 2 VAS. At least one of the things. Now, it's important to recognize the European guidelines also at one point recommended HAS-BLED. Although what I'd highlight is none of the randomized trials that approved the therapies used CHADS 2 VAS. And none of the randomized trials that got the therapies approved used HAS-BLED. No, so how did we get there? Why are all the clinicians in planet Earth using CHADS 2 VAS when none of the trials used it? Well, I think everybody wants to weigh risk versus benefit. And it's easier to weigh risk versus benefit once the new drugs are out. But when the new drugs were being studied, it's important to recognize that warfarin had been studied in about a total of 4,000 to 6,000 patients in atrial fibrillation. Now we have 75,000 patients of randomized data. So when warfarin was studied, it was studied against aspirin or placebo different times, and Bob Hart did a meta-analysis, and the INR was 2 to 3. So when people think about new drugs, they thought, oh, we should check the bleeding and then check the ischemia risk and then make a calculation. But in essence, what the new drugs showed us is that compared to warfarin, they had dramatically reduced the risk of fatal intracranial hemorrhage, which is one of their key steps, and that they had improved at least the ability to stay on the therapies that then led to less stroke. So HAS-BLED wasn't used and would not likely be used. So I often say, we use CHADS 2 VAS. Really, you just want to know whether or not you should treat the patient. I think CHADS 2 VAS is fine. The next most important thing I think about is creatinine, because it measures renal function, measures age, weight, sex, creatinine, which is a good measure of vascular disease, diabetes, et cetera. So everything in CHADS 2 VAS except the prior stroke can be measured with that. Next question, are all the NOACs the same in terms of efficacy? Yes or no? You should tell me what you think about that. Is bleeding associated with a drug or a patient characteristic? You should tell me what you think about that. So as you think about NOACs and bleeding or efficacy of the drug. I'd be interested what you all think. So here I'll go back to the EHRI, and this is the Heart Rhythm Society in Europe. They have some thoughts. They highlight 3 things that I'll go through: renal impairment, age, and diabetes. Age is a measure of vulnerability. You know, I participated in ROCKET. I'll just say all of the DOAC trials have older patients, but look at this. 75 or greater was represented in 43% of patients in ROCKET AF. This is the oldest ambulatory population study that I'm aware of for the blood thinning. And if I look at that, outcomes of these patients, you can see, in fact, again, that they had similar outcomes to the overall trial, except that the older patients have even higher event rates with warfarin, over 75, and the same hazard ratio, if not better, seen with Roxban. How about renal function as a measure of vulnerability? John Piccini at our institution, after we finished ROCKET AF, said, hey, why don't look at predictors of stroke and systemic embolism? If you look here in the post hoc analysis of the trial, after prior stroke or TIA, the next most predictive thing of stroke is renal function. Obviously, because renal function captures some of the features below it. Age is part of renal function or creatinine clearance. Sex is part of it, like I said. You could imagine creatinine captures blood pressure, diabetes, hypertension, other values. So we even looked and said, look, stroke and a history of renal function had the worst stroke rate. Stroke and a history of stroke, no history of renal function, or renal dysfunction, no history of stroke, had similar. And then if you had neither, it was lower. We even had a score, R2 CHADS 2. Didn't take off the same as CHADS FAST, but you could imagine that we were thinking that the strongest scores after the clinical trials for prediction of stroke was actually adding in renal dysfunction. Well, what about dabigatran? How did dabigatran form? It was an open label study in the sense that it was compared to warfarin open label. But when the trial was presented, I would tell you, I was very excited because I thought, now finally, for the first time, we have a therapy that is beating warfarin. Remember, warfarin was, as I like to say, the Muhammad Ali of anticoagulants. It was 50-0. It had been 50 trials. We don't like it. Nobody wants to use it, but it had not lost. Until dabigatran, 110 and 150 was shown to be better or at least the same as warfarin. And these are not new data, except that I think putting them into perspective to say, when they designed the trial, they had one dose that bled the same as warfarin but had less stroke, 150, and one dose, 110, that had less bleeding but similar rates of stroke. And obviously patients with creatinine clearance less than 30 were excluded. The FDA in the United States did not approve the 110 dose. Why did the FDA in the United States not approve the 110 dose? The dose that was shown to have less bleeding but similar rates of stroke. And they said, well, why did the FDA approve a higher but not lower dose of dabigatran? And in this paper, which was interesting, they said based on PK/PD data, they thought renal dysfunction they should use with 150, it increased the 6-fold exposure. So they approved 75 milligrams. And none of the randomized trials look at renal dysfunction. And they often said most dose adjustments there are based on PK/PD data. So what the FDA was fundamentally saying was that we don't trust physicians. We think if we give you 2 doses, one that lowers stroke and one that lowers bleeding, everybody will choose one that lowers bleeding. They will not choose one that lowers stroke. I thought, how can this be? The FDA is so pedantic. Doctors know how to work with patients. We should see what we find. Later on now, I'll say it's interesting what I see about the FDA. So this is the 15 milligram dose of rivaroxaban with warfarin. You can see that there was a significant number of patients that were in the trial that had at least the same similar benefit. These are the patients as the renal function decline. ROCKET AF, again, we see that these patients had a reasonable effect. Quote unquote overdose patients somewhere between 15 and 20 milligrams seem to do okay. And how about your renal function in ROCKET AF? Does it worsen over time? And as you can see, over time, patients treated with Xarelto or rivaroxaban had less worsening renal function. And this has been observed both observationally and in the trial. What about apixaban? The apixaban dosing was, as you all now know, the ABC criteria: age, body weight, and creatinine greater than 1.5. You got the 2.5 milligram dose of apixaban in Aristotle. Powerful study conducted by my colleagues at DCRI also, and was able to show, as you all know, reduction in bleeding and similar, if not less, stroke. As the renal function worsens, you can see that the effect seems to be consistent for both stroke and major bleeding. So here's my second myth or key learning. Which one causes less bleeding? Twice daily dosing or once daily dosing? Which one causes less bleeding or stroke, peak or the trough of the dose concentration? This is talked about a lot because people say, well, Manesh, apixaban bleeds less than rivaroxaban because the drug is dosed twice daily. I think this is a myth. In fact, let me show you why. These are data from edoxaban, not related to rivaroxaban or apixaban, but you can see here, this Jeff White's data, Stuart Conley and others, where this was the fourth NOAC to come forward. This is a phase 2 study of edoxaban in AF patients that they followed for 12 weeks. They took 1,200 AF patients. They took 30, 60 milligrams once daily of edoxaban, and then 30 twice daily and 60 twice daily. It was a dose-finding study where they looked at major clinically relevant non-major bleeding at 12 weeks. And 35% of the drug is supposed to be excreted by the kidneys. So here's the first message. Here's the peak dose on the left, the minimum dose of the concentration, the peak and the trough, and then the area under the curve. And so I'll make your eyes here look at 60 milligrams once daily, 30 milligrams twice daily. The maximum dose is higher for 60 milligrams once daily versus 30 milligrams twice daily. The minimum dose or the trough dose is lower for 60 milligrams once daily versus 30 milligrams twice daily. So you can see that the area under the curve, though, is exactly the same. So once daily dosing has more variation, higher peak, lower trough. Twice daily dose has more consistent area under the curve, which is the same. So the peak and the trough are less variable. So less variability if you go twice daily versus once daily, but the peak and the trough are the same. And that you can see the total exposure is identical. So higher peak, lower trough, exactly the same area under the curve or concentration exposure for the same drug in atrial fibrillation patients provided twice daily versus once daily. And here's what the bleeding showed. I just want to highlight this is important. So over here on warfarin, you see 22 out of 250 bleeds. Obviously 60 milligrams twice daily had the most bleeding. But when you look at 60 milligrams once daily versus 30 milligrams twice daily, the 30 milligrams twice daily had higher bleeding. The same drug given twice daily at the same dose compared to once daily has more bleeding when you give it twice daily. So how can twice daily of a drug lead to less bleeding unless the dose is less or the patients have less bleeding risk? So this is important because the edoxaban investigators then went on in the trial to actually look at 24-month trough concentration in the patients to look at ICH, ischemic stroke, and major bleeding. And this is the trough concentration of edoxaban at the bottom, the probability of an event over 3 years. The first message is that intracranial hemorrhage has very little relationship to the concentration of the drug. It probably doesn't cross the blood-brain barrier. It probably doesn't cause tissue factor inhibition like vitamin K does. And so this points to a warfarin hazard that all of our patients were facing. That's why these new drugs, all of them, are better than warfarin. There's a broad range of concentration to where stroke and ischemic stroke reduction can happen, especially as you figure that out. Ideally, you want that concentration to be somewhere back here where you have less stroke similar to the bleeding. But bleeding has the largest variability. So the same sets of patients in this trial could have a edoxaban concentration of 90, and they would have hugely variable bleeding, somewhere between 3 to 4-fold different, pointing to not the fact that it's the drug concentration only, but obviously it's patient characteristics that drive bleeding. So why do I go through all that? I go through all that to say that when you're thinking about your AF patients, you want to use drugs to treat the patients you see, like the trials that you might have seen. Just give me just a second here. I will take 1 second, sorry, to go take a look at something.
according to this.
Any comments, Dr. Karandikar, so far? Dr. Karandikar, are you there?
Hello.
Yes, NG, Dr. Professor, any comments? What do you think? He has mentioned a very important point that, your twice a day versus once a day, really, it's a myth. So in your practice, how do you choose, just to keep the discussion going till he comes?
Yeah. I think atrial fibrillation and the NOACs is a topic of great research, and everybody is coming out with different forms. In fact, I was part of the Redual PCI international trial, and in that it was again whether to add aspirin to a NOAC, whether to add or which NOAC to use rather, has been a point of great amount of research. I think there are several pluses and minuses, and I think I would like to listen to the rest of his talk before commenting any further. Let me see his conclusions. What his choice for atrial fibrillation? Number one, atrial fibrillation patient needing coronary angioplasty, and what drugs do you use after angioplasty in a patient who has atrial fibrillation? And there he comes, and I would really like to listen to his talk completely before passing any comments.
Sorry, guys, I apologize for being just a quick step out to check on a pacer. No problem. Okay, so I apologize for the interruption. So what drug is best studied for patients with renal dysfunction? Then I look forward to the conversation. So here's apixaban was studied in 18,000 patients. 2.5 milligram dose was used in 428 patients. Rocket AF, 14,000 patients. The 15 milligram dose was actually used in 1,400 patients. And you can see Engage and Rely, of course, had a randomized lower dose. I highlight this just to say that the 2.5 milligram dose of apixaban with patients with renal function was studied in 149 patients, or 1% of patients. So I like to often say there are effective doses of DOACs. The dose that's been studied of apixaban is 5 milligrams BID. The 2.5 milligram dose we know very little about. So when you see observational data that says the 2.5 milligram dose bleeds less, well, I think it's probably because it's being used in sicker patients, but it also may stroke more. Well, does that really happen? Let's go look and see what happens. So what the FDA was right about, and this is what shocked me, is remember I said they didn't approve the 110 milligram dose in the United States because they thought everybody would use it. So the 110 milligram dose is the predominant dose worldwide of dabigatran, saying that doctors, maybe I don't even know if patients, but doctors are so scared of bleeding that they use the lower dose no matter what. They don't choose the 150, they really choose lower dose. Look at the apixaban, 2.5 milligram dose. It's a little older data now. Unfortunately, India is not on here, but look, Australia, 40% of patients are getting the 2.5 milligram dose. Germany, 43% of patients were getting the 2.5 milligram dose. Even with rivaroxaban, the 15 milligram dose, Belgium, 40% of patients are getting the 15 milligram dose. So you have to use the right dose. You have to use a studied dose. And it's important to recognize that at least for some of these drugs, 110 compared to 150 is not near 50%. 15 milligrams versus 20 milligrams for rivaroxaban is a quarter reduction. 2.5 versus 5 is a 50% reduction of the drug. So not only is it a dose adjustment, is what's the dose adjustment and is it the right one? And again, this is just another way to show you the differences across the world and the prescription patterns of which drug and which time. And then this is important in the United States because it's not randomized, it's observational. But when we looked in the United States to say, look, the people who got the lower dose, and these are patients who got the lower dose without renal indication, so they're likely older, sicker looking patients, they had higher stroke. Well, that's not too surprising. I would think if you lower the dose in sicker patients, you might have higher dose stroke. But what you also see is bleeding. Look at the bleeding. The reduced dose rate of bleeding was 6% versus 4% in the patients who had the reduced dose of apixaban, whereas when I look at the reduced dose of dabigatran or rivaroxaban, even when it's not renally reduced, they're closer to the overall major trial drug findings. So reducing dose here has a bigger effect. The other myth that I would say is that one drug's better for renal dysfunction than the other. This is renal AF. This is the only randomized study I'm aware of that has apixaban versus warfarin, 5 milligrams twice daily versus 2.5 and 2.5 twice daily selected patients. So first is that the company and the sponsors, when they were trying to figure out what renal dose to use of apixaban, they chose 5 milligrams again compared to warfarin. These are end-stage renal disease patients. They were looking for bleeding. It was stopped early due to enrollment. One could argue it could have continued to enroll. What would we have found? 154 randomized patients. Time to major or clinically relevant non-major bleeding by intention to treat. Apixaban's 31%, warfarin's 25.5%. Bleeds more than warfarin. So myth number 2, be very careful about using DOACs in end-stage renal disease. If you have to use it, you have to find the right dose. I don't. This is the dabigatran, rivaroxaban, edoxaban dosing chart. And as you can see, again, this is the dosing. When you get below 50 milliliters per minute, you should start to think about which drug you're using. 2.5 milligrams, it's not actually EGFR based, it's based on creatinine, age, and body weight, so you have to choose that correctly. And then you have to think about how many of my patients look like the patients that are in this trial. So how do you stop bleeding? You reduce medications. You stop aspirin. We've now got randomized trial data that shows people with coronary disease who have atrial fibrillation, if they're randomized to DOAC plus aspirin versus aspirin alone, DOAC plus aspirin versus DOAC alone, the DOAC alone arm wins. A fire published in the New England Journal showed that with rivaroxaban, but other studies have shown that too. So unless somebody recently had a stent, we usually try to not have them on antiplatelet therapy with coronary artery disease. Reducing the dose per se doesn't reduce bleeding. You're usually reducing the dose because the patient's at a higher stroke and bleeding risk. And these are the pooled events across 4 trials that show us that the DOACs in fact do work. And the fixed dosing, they have no need for anticoagulation monitoring. They have food-food drug interaction. So this is the first year, 2022, 10 years after these drugs were studied, that we're going to have the therapy get to more than 50% of patients worldwide. So why do we use real-world data? We take the patients that we've studied. I wish they were more diverse across the world, but they're not. Then we have to use them in all the patients we see in clinical practice. And so we use real-world data to say, is it consistent? Is it the same as we saw in the trials? We don't use it to tell if one therapy is better than another because it doesn't have randomization, and doctors make decisions based on a lot of unmeasured confounders. We've seen this for sure in the drug trials. So I told you what the efficacy and the safety rates were in Rocket AF for rivaroxaban. If I go into the real world and look at patients who are less risky, I see lower event rates of stroke and bleeding and very low ICH and GI bleeding rates. So it helps me to highlight for you that it's the patient risk that drives some of the event rates. I'll end with diabetes. Unfortunately, it's probably the most common, and in addition to obesity, the most common condition we treat worldwide. Diabetes is particularly important because it seems to go with renal impairment, and now we have GLP-1 and SGLT2 inhibitors and a variety of other therapies that we're using for diabetic patients. The CHADS-2 or the CHADS-2 VAS score, of course, has diabetes in it. So having patients that are across trials with multiple comorbidities that have diabetes represented is important. It's worth, again, to look at the patients that you see, were they represented in the trials or the data that you are referencing. And we've seen this across both a set of observational data where rivaroxaban, apixaban, and edoxaban seem to do better in the diabetic patients. There's some variable rates there, as you can see. And then when we've looked market scan retrospectively, we've seen that the diabetic patients and patients with non-valvular AFib, their worsening of renal function seems to be a little bit better with the NOACs versus warfarin, where warfarin has probably a calcification process in the arteries that we know about. If you look at diabetes, renal dysfunction together, those patients have some of the highest rates, as you can imagine, especially when the GFR is less than 60. And preventing stroke and systemic embolism in those patients is probably the most powerful thing we can do. These are the data from Rocket-AF from Samir Bensal. It's a subgroup showing, again, similar findings. In fact, this is an interesting problem. Subgroup analyses, the ESC guidelines say that, if you look at bleeding across diabetic patients, again, you see similar rates for all the therapies except for apixaban. It's hypothesis generating. It shouldn't be taken too seriously, although it does make you wonder, is it the fact that the diabetes rate's higher or that the non-diabetics are so low that we wonder how can the bleeding rate be less than 0.5%? Either way, caution is provided to you by both the FDA and ESC. And then many have shown us across now, if I think about not just the trial, how about retrospective data in the United States? How about Taiwan? There's also now Indian analyses so that we look across Asian populations and we see consistent findings for these therapies, especially some dosing therapies like the rivaroxaban. So let me end, because I know I was interrupted a bit, but I want to make sure there's time for questions, because I know that's probably part of the most fun of this sessions, is that patients with comorbidities have significant risk. And those patients with comorbidities have significant risk, and those risks include elderly, renal patients, diabetes. They're represented, many of the trials probably represented most in Rocket-AF. When you see real world data and you see myths like twice daily dosing versus once daily, or this drug's better than that drug, I don't think we know that any drug's better than the other drug. What we do know is they're better than warfarin, and that you should be using the drugs at the doses that you see in the clinical trials. And then I would say, consider the patient in front of you. So the key questions in the field now are, how long do you have to have AFib to be treated? Can you do pill in the pocket? What happens when somebody needs a left atrial appendage closure? Who do you put that in, Manesh? And will the new drugs, the factor 11s, be better than the factor 10s? Just to highlight for you, the ways that we're studying those is we're thinking about the patients that are at the worst risk for bleeding and stroke who are inappropriately dosed. Those 2.5 milligram apixaban patients, or those patients who don't have the right dosing. So thanks for listening to my lecture. I apologize about being interrupted. The keys for you in practice when you think about myths in atrial fibrillation is, how do you take your trial findings of sicker patients to healthier patients? When we took our trials, we tried to take the sickest, most representative population. What we've seen is people have taken lower dosing strategies for older, sicker patients, and we worry about that. So I'll stop there.
Thank you, Dr. Manish. That was an excellent presentation. A few questions. We'll start with the discussion. First, I would like to ask you the limitations of CHAD2-VASc. The whole thing is based on CHAD2-VASc. There are patients who have recurrent atrial fibrillation. The score is less than 2. They have a longer duration of atrial fibrillation, score less than 2. They have not looked at the anatomy, LA appendage, LA size. So what do you think is the limitation? Because that's the only score we use for NOACs. So your comments on that.
Yeah, so the first myth I highlighted is that the trials actually use CHADS2, not even CHADS2-VASc. Why did the trials use CHADS2? They used CHADS2 because at that time, warfarin was not indicated for patients with a CHADS2 score less than 2 or 1. So when we did the non-inferiority trial with Rocket-AF, we said we at least have to have a CHADS2 score of 2. We were worried that if you had 1 or 0 and you showed you weren't better than warfarin, you wouldn't get to market. Now we're at market, and then we have drugs that are lower risk. And so your limitations are very important. The indication for an anticoagulation isn't some magical algorithm. It just tells you a patient's risk. As you said, clinical expertise should matter. So a young patient with a atrium, or a middle-aged patient with a left atrial of 6 and chronic AFib, and potentially even some other, let's say one other risk factor, that patient probably is at some of the higher risk with recurrent AFib that we've discussed. So I think the limitations for CHADS2-VASc exist both in age, because age is a very big driver, but non-biologic measures. So usually I'll call them imaging measures, BNP. We've seen now with our colleagues from UCR in Sweden that they've added a BNP to the scores and some biomarkers that highlight risk of stroke. The second is imaging measures, the amount of valvular regurgitation in the left atrial appendage, the disorder of the atrial fibrillation. And the final, of course, is a patient's ability to take therapies, which I'm sure drives some of it.
Okay, the second one is in your practice today. I know you have given us beautiful data on different myths, but in your practice, out of these 3 NOACs, what is the commonest to use, or you really feel it's all patient profile dependent? Whatever you use, it's the same.
No, I mean, I think we probably use it varies everywhere you go, but we probably use the most rivaroxaban compared to others. And the reason we use rivaroxaban, one, is because we have data and we feel comfortable in the sicker patients with renal dysfunction and the sicker patients with diabetes. So, what you have to ask yourself is, do I feel comfortable using a therapy that was studied in sicker patients in healthier patients? Or do I feel comfortable using a therapy that showed something in healthier patients and assume it's going to work the same in sicker patients? So when we extrapolate, we're going from a higher risk population to a lower risk population rather than the other way around. Additionally, doctors can't learn or can learn a lot of things, but we tend to learn one or two therapies well. And so we learn rivaroxaban because of the dosing for stroke and systemic embolism, but we also use it for VTE, and we also think about it for vascular disease. And so there's a variety of indication opportunities there too.
Thanks. I would like to ask Dr. Jagdish Hiremat. He was actually one of the very early users of Novax. So I would like some comments or questions from Dr. JSH, please.
Yeah, thanks. After, say, nearly 10 years, we are almost on par, the three of them. Sicker the patient, probably rivaroxaban has a better statistical analysis, no doubt about it. But most of the times, the tosses depends on what the patient profile. I would go by where the patient is fitting into which trial. That is what my thinking is. And if the patient fits into a trial, would go by that. But certainly for renal patients and elderly patients above, the choice is apixaban. And otherwise it is rivaroxaban for sicker patients and renal patients. But otherwise it is hardly to choose between the three because they are big trials. The data is almost on par. There can be some hair dissection and one nose ahead of the other and a tail behind the other. But it probably in real world practice, it makes very little difference.
Any other questions, comments, Dr. Karandikar? Dr. MSH?
Your final conclusion slide mentioned rivaroxaban effective in diabetes, renal cases, and so on. And even, I believe, I don't know about others, but in my own personal practice, I use rivaroxaban the most. Now, what I want to ask you is, the doses range with rivaroxaban, 2.5 milligram at one end and 20 milligram at the other end. I use both the strengths. I remember one patient with peripheral embolism, 20 milligram is something which I had started with, but that is besides the point. I would like you to briefly highlight in which group of patients, what dose you recommend, and especially the subset of atrial fibrillation patients who have undergone coronary angioplasty. Atrial fibrillation and fresh coronary angioplasty, what do you do?
Yeah, thanks. So first of all, there's a broad range of doses because there's a broad range of conditions. And assuming that venous thromboembolism, both treatment and prevention, or atrial fibrillation and PCI, or just chronic vascular disease need the same dose would be rare. And in fact, rarely, I think, in medicine have we ever had such a dosing program. Just to be clear, over 100,000 randomized patients with these different doses. So we should feel fairly comfortable learning those. I'll walk you through my algorithm. It's not perfectly simple, but the way I think about it is a pyramid. The top of the pyramid is the highest dose, which is 20 milligrams or dose adjusted 15. At the top of the pyramid is atrial fibrillation. Most patients with atrial fibrillation need that dosing. And if atrial fibrillation is present, but you also have vascular disease, you should be treating for atrial fibrillation. So what I mean by that is if you had chronic coronary disease, you still use the 20 milligram dose or the 15 milligram dose reduction. I'll come to the PCI conversation because it's an acute issue within atrial fibrillation in just a second. Next is VTE. If you don't have atrial fibrillation and you have venous thromboembolism, then you have acute treatment, which we know is twice daily dosing followed by 20 milligrams. And then we have chronic prevention, which we know is 10 milligram dose. Now, actually, what's powerful is that chronic prevention dose, and I would argue the VTE randomized trial data of rivaroxaban is some of the most powerful. We can decide how long we have to treat our patients, but for VTE prophylaxis, the Einstein choice and other data have shown bleeding rates similar at 10 milligrams to aspirin, if not lower. So it tells you again about the population and the importance of that. And then at the base of the pyramid, they don't have VT, they don't have atrial fibrillation, they have chronic coronary vascular disease, peripheral artery disease, CAD. Then it's 2.5 milligrams in addition to aspirin, well studied, because again, you need a little bit of antiplatelet with antithrombotic when you're chronically treating low-level atherothrombosis. Okay, so AFib, VTE, chronic coronary disease. What happens when I put a stent in? When I put a stent in, not just with rivaroxaban, but with a variety of trial data, we know that you can shorten how long you have to use the DAPT if you use the NOAC or the DOAC also. So first thing we do is we use aspirin and usually clopidogrel with rivaroxaban or apixaban, usually rivaroxaban, and we stop the aspirin somewhere around 2 to 4 weeks, and they stay on clopidogrel. Then the second question is, what dose of rivaroxaban do they use? And generally, the first question I ask is, what's the renal function? If their renal function is not normal, because of these patients are often sicker, then I have a great set of data to use 15 milligrams of rivaroxaban. Two sources. One is it's renal dose adjusted from Rocket AF. The second is it's Pioneer, which used the 15 milligram dose. So you could use either of those two doses. Some people would say, well, Manesh, Pioneer had the 2.5 milligram dose, and we've seen in chronic coronary vascular disease the 2.5 milligram dose. Can I use that with my DAPT or shortage of that? In that Pioneer trial, DAPT was generally continued, not dropped as much, could be dropped, but not as much. With the 2.5 milligram dose, I tend to use that more for chronic coronary vascular disease. I do not know the long-term stroke prevention with 2.5 milligrams in atrial fibrillation patients. So I don't use 2.5 milligrams for AFib patients. For AFib patients, I use 20 or 15, and then I do the decision.
Thank you, Dr. Patel. I think we are running out of time. Dr. Sethi, over to you.
Yeah, so we have had an excellent talk by Dr. Manish Patel, and thank you very much once again from CSI Pune for giving your valuable time for this meeting. And thank you, Dr. Sunil Sathe, for an excellent discussion. Now we will move on to the next talk. The next talk is by Dr. Patrick Sarez, and I would now hand over to Dr. Patel to introduce our next speaker.
Which looks okay. Next view.
Hello. Yeah. The next talk is on.
This is another view.
I think there is someone's mic which is on. So let's move on to the next talk. Precision medicine for decision making between CABG versus PCI in triple vessel disease with or without left main. So topic is very interesting and very broad. And to speak on this talk, we have Professor Patrick W. Sarez. He's a world-renowned expert in interventional cardiology and imaging with more than 4 decades of experience in clinical trials and innovation in medicine. It is truly my honor to introduce him. He has pioneered several interventional procedures like devices such as bare metal stents, drug-eluting stents, biodegradable stents, and TAVI, as well as imaging techniques including quantitative coronary angiography, quantitative IVUS, OCT, spectroscopy, and so on. For 20 years, he was Chief of Department of Interventional Cardiology at Thorax Center, Rotterdam. Professor Patrick Sarez is currently established Professor of Medical Intervention and Innovation at National University in Ireland, Galway, and Honorary Professor of Cardiology at National Heart and Lung Institute, Imperial College in London. He is recipient of many awards, and to name a few of them, James B. Herring Award by AHA in 2006, Lifetime Achievement Award by American College of Cardiology in 2011, Gold Medal Award for Outstanding Contribution to Science and Practice of Cardiology from European Society of Cardiology. He has huge publications in the leading medical and cardiovascular journals, and there are more than 3,500 manuscripts to his name. He is the founder and past editor-in-chief of Eurointervention Journal, which is the official journal of European Society of Cardiology. Current and past member of editorial board of more than 30 international journals. He is also co-editor of European Society of Cardiology textbook of cardiology. And to say over and above, He is a father of interventional cardiology across the world. To moderate this session, I would like to invite Dr. Shirish M.S. Hiremat, who is one of the senior interventional cardiologists from Pune. He was director of cath lab. He is a director of cath lab Ruby Hall since last 4 decades. He's a past president, CSI 2017. He's a convener of National Interventional Council 2004 to 2006. He has a great experience in left main, carotid angioplasties, bifurcations, and CTOs. He's also a teacher to many cardiologists practicing in various parts of country, including myself and Dr. Rajiv Sethi. Over to you, Dr. Hiremat, sir. Please take the proceedings forward. Thank you.
Patrick, welcome to this scene. We are all here on on Saturday evening, and very eagerly awaiting to hear your comments on multivessel disease, including left main and without left main, whether to go for cabbage or we can manage with PCI. I think this scene had changed again and again in last 10 to 15 years, talking on this particular issue. And we would probably hear the latest, the way you think on this issue. Go ahead, please.
Thank you very much, and thank you for all these kind work. It looks that we have achieved a lot all together. So you have seen the title. It's today I'm virtually in India, but let me see. I'm virtually in India, but to be honest, there is, as you could see, also a small Indian team in Galway in the Corrib lab, and among all these ladies, there is Dr. Prudvit, which is doing a very good job here in Galway. The first thing I would like to discuss is what we call the average treatment effect versus personalized care and individualized prediction of mortality. You know, this is what we have published with Jean Bronwal and Mark Sabatin in the Lancet this year. That's the mortality in Syntax, Pre-Combat, Excel, and Noble. Altogether, 4,394 patients in these patient-based meta-analysis. The patients were in the past evaluated by a heart team to be equally suitable candidate for either PCI or cabbage. This is the 5 years follow-up. Mortality in PCI 11.2, in cabbage 10.2, hazard ratio 1.10, non-significant, that's in the Lancet, and absolute risk difference of 0.9, also not significant. Now, this is important because it's the relationship between cardiovascular mortality and anatomic syntax score. You know, the anatomic syntax score has been there for more than 15 years now. That's just quantifying the extent and complexity of the coronary artery disease. And 13 years after its introduction, a high-risk score above 32, according to the SC guideline, is still of prognostic value, it's still working. You can see here the hazard ratio for PCI and cabbage. Until 33, it works quite well. I mean, there's no difference in all-cause mortality between bypass surgery and PCI. But when you go above 45, then PCI is an absolute contraindication and you should go to surgery. Now, this is 10 years follow-up in a trial that I know very well, Syntax, with the extended follow-up of these patients, 1,800 patients. In red, you have the PCI with a mortality of 28.4. In blue, the cabbage, again, an absolute risk difference of 4% this time, and an hazard ratio of 1.19 with a p-value of 0.066. Now, the question is based on the average treatment effect should you send all your patients to surgery? And the answer is, of course, no. Now, we are making progress and developed decision tool to improve personalized care in cardiovascular disease. We are moving from the heart of medicine towards science. In the panel A, you see what we call average treatment effect assessed in an heterogeneous population. That's the heterogeneous population. You submit to a treatment, and there are individuals in green, which is expected to derive benefit from the treatment. The blue will be equivocal of equipoise, and the red will be expected to be harmed by the treatment. So the global effect is something which is multicolor, and basically we try now to identify in advance the heterogeneous response to the treatment. We want to know in advance the expected to be harmed by the treatment, the expected to benefit from the treatment, and those will be equipoise with the two alternative treatment. So we developed and published in the Lancet for the second time the syntax score 2020. We have redeveloped the syntax score published in 2013, also in the Lancet, but this time we can predict 10 years mortality and 5 years MACE in the trial, and we have externally validating freedom of Valentin Förster, multivessel disease and diabetic, BEST multivessel disease, pre-combat, main stem, and Excel. And you see they have 7 clinical parameters: the age, the creatinine clearance, the ejection fraction, the diabetes, the peripheral vascular disease, the COPD, and then what we call 2 effect modifier, the anatomic syntax score, and the 3 of left main vessel disease. And at the bottom, you see a probabilistic formula with a lot of parameter. If you send the patient you want to send the patient to surgery, you have to use the parameter in blue. If you intend to send the patient to PCI, you should use the parameter in red. The coefficients are quite different. And you can also predict the 5 years MACE. Let's discuss that a little bit in details. What you see here is what we call, technically speaking, calibration plot. It's just a regression line. You see 4 quartile of the whole population of PCI and CABG in the syntax study. And basically, you see a quite good correlation between the predicted mortality with the observed mortality, the predicted mortality on the horizontal axis, and on the vertical axis, the observed mortality. And in these 4 quartile, through these 4 quartile, you have a nice regression line with a good slope and a good intercept, not only for PCI, but for CABG. That's very important. That means we can predict something. And here we have, again, a regression line, but this time it's the difference in 10 years mortality. And we call that survival benefit of CABG versus PCI for mortality. Here you have the predicted treatment benefit of CABG versus PCI, and then the observed. Now here's the first quartile, and in this first quartile, PCI is better. As you could see, it's better. Now the second quartile is really on the line, so it is what we call equipoise. And the last 2, obviously, surgery is better. Now what we can do is we can translate these 4 quartile in Kaplan-Meier curve. And in the first, PCI is better. That's the red line on top of surgery, which is in blue. And as you could see, the absolute risk difference is in favor of PCI. In the second group, they are equipoise, the 2 curves, the 2 Kaplan-Meier curve for all-cause mortality as superimposed, difference close to 0. Then in the third quartile, you start to see that bypass surgery has a better survival than PCI over 10 years, and that's still increase of amplified after in the last quartile. Now, this is important because when you have that score and you have an individual with anatomical Stentac score 35, the age 83, 79 creatinine clearance, ejection fraction 55, left main no, gender male, COPD no, peripheral vascular disease yes, diabetes no, not smoking. Here we have the 5 years MACE. Of course, that individual is 83, but with PCI, nevertheless, at 5 years follow-up, the rate of MACE will be 55 with PCI, 35 with CABG, an absolute risk difference from 19.7. And in terms of mortality, is elderly, 79% mortality at 10 years with PCI, 61 with CABG, and absolute risk difference of 17.9. We use this score all the time. This is not yet published. It's 2022. It is in the multi-talent using the Supraflex of the company SMT versus Synergy. We use that score. And that's how we use it. I mean, this is an example of individual predicted mortality at 5 years, this time in a surgical registry, and I will talk about that a little bit longer. So you have this patient, that's case 1 in green here, is 55, no diabetes, no insulin, no PVD, no COPD, creatinine clearance 75, good ejection fraction, no smoker, and a relative good anatomic syntax score. If you go to PCI mortality at 5 years, 8.7, with PCI, with CABG 5.7, minimal difference. The patient is here, you know, the prediction is very close to, but if you go to case 2, age 74, diabetes, not insulin, no PVD, no COPD, but creatinine clearance, ejection fraction is okay. Smoker, yes, is smoker, no left main, but the 35 anatomic syntax score, then the difference in absolute risk, absolute mortality is 15%. And that patient, which is here, should be to surgery. Second point, validation of the Syntax 2020 in the Credo Kyoto registry. You know, that's an amazing registry from my friend Takeshi Kimura. We just published in the GACC, external validation of syntax score 2. You know, in these 3 core that he has collected, the most recent as a 5 years follow-up, only with 3 vessel disease and left main, big numbers. You could see that the surgeon used almost all the time the Lima, 97%. They use a new generation of drug-eluting stent in 90%, and intracoronary imaging 83%, because fortunately in Japan it is reimbursed. And again, we did the same trick. You're now expert in calibration plot. The syntax score 2 2020 show helpful discrimination and good calibration for predicting 5 years mortality. This time with that big population, we, instead of using 4 quartile, we use 10 quartile. And as you could see, there is not too much difference in survival in the first 3, 4, 5 quartile, a bit chaotic here, but basically here there is very little difference in observed mortality and in predict mortality. If you go here, there are 4 decile where clearly the observed mortality is higher, of the benefit in survival is better with CABG and also in prediction. So basically this is equipoise, basically it is CABG better. And what we did, we regrouped these 6 decile and these 4 decile, and then we have a new acceptable absolute risk difference in mortality of 4.5%. And why we say that? Because if you take the Kaplan-Meier curve of all these patients, and there is, as you could see, almost more than 4,500 patients, you see a very little difference of mortality, non-significant after 5 years. In that group here, you could see that the mortality will be quite different at 5 years, 31.6% and 21.9%. In other words, these patients have to go to surgery. These could go to PCI or bypass surgery. And again, you have seen that cartoon, but now note we have more than 7,000 patients, And I would say up to here, 4,500, you can go to PCI. That's the conclusion in the Credo Kyoto. You can go to PCI for all these patients. These patients where you see the divergence between the predict mortality between PCI and CABG, and also the divergence, that's the dotted line for the observed, they should go to surgery. Next point is from the anatomic syntax score derived from invasive coronary angiography. We have been moving to the coronary compute tomography angiography, CCTA. And we did that around 2013. So we replaced progressively the conventional cine angiography by the multi-slice CT scan, which give you the anatomy because it's three-dimensional, it's easy with machine learning to have an automated detection of all the segment, 5 for the main stem, 6 for the proximal LED, 9 for the diagonal, 10 for the second diagonal, mid LED, distal LED. That's what the deep learning is doing very well. And the accuracy is 97%. And on top of that, with the multi-slice CT scan, we start to have good ID because it's three-dimensional about the length of the lesion, about the amount of calcium that you have in the lesion, about the tortuosity in three-dimensional, and diffuse disease. If you look at the area function here, if of diameter function, if it's less than 2 millimeters or more than 75% of the vessel, like you see in these LED, that's qualified as diffuse. Now, we felt in 2018 that we were ready and confident to use the coronary computed tomography angiography for the heart team decision-making in multivessel coronary disease. And I must say that the editorial of this gentleman, including the current president of the European Society, was very laudatory. This study may be signaling a shifting paradigm in which CAD is diagnosed and thoroughly characterized non-invasively, and revascularization planning made in a collaborative fashion, integrating the heart team and a wealth of non-invasive data that will hopefully lead to more effective and cost-efficient revascularization strategy. This is the last theoretical slide that I'm showing you, is the study in itself. Instead of randomizing patient, we did randomize the doctor in a virtual trial. So we had patients with left main of 3-vessel disease, 223 patients. They were diagnosed by invasive conventional angiography, but after that, they get a CTA. All of them get a CTA, multi-slice CT scan, GE revolution. And then there was 2 R team. One R team could not see the CTA, had only access to the invasive cine angiography conventional, and the other R team has only access to the CTA. And the primary endpoint was a decision-making and treatment based on the syntax score 2, made with only the conventional angiography or only with the CTA. And we were expecting a kappa. Kappa is a kind of concordance statistic of 0.6, we would have said the trial is positive with 0.6, and it was 0.82. And in the statistical jargon, the expert will tell you that it's almost perfect. That's the word they use, almost perfect. If you want to understand more simply what was the concordance between the two decision-making, it was 92.8%, and there was a secondary endpoint with the flow. So we're coming now to the most exciting part, which is decision-making to treatment planning based on the sole guidance of multi-slice CT scan in patients with three-vessel disease and left main. And that's the fast-track trial that we are running right now. We have passed halfway. It's a very exciting thing because the real thing has started. The fast-track CABG trial, there are patients referred to CABG by a conventional heart team using invasive coronary angiography, ICA. They also get a multi-slice CT scan with the FFR CT of heart flow. Then they came to our core lab in Galway. We analyze a lot of things that you're going to see, MPR, cross-section, MIP, etc. And then we give advice to the surgeon and said, you should put your bypass here and there. And the surgeon does not have access to the cine angiography. If he's not comfortable or if he found the image of poor quality, he can ask the conventional cine angiography. And then he's unblind. That's basically the feasibility assessment. But if he's okay with the multi-slice CT scan only, then the CT planning and operating heart team will put the bypass with the sole guidance of multi-slice CT scan. You will have the bypass surgery, and then as a safety assessment, we look 30 days later, are the bypass at the right place and correctly implanted. Now, I will finish by one case in great detail. PCI of CABG, gut feeling, clinical flare. I've been doing that almost all my life, or precision medicine. That's something that I'm more and more practicing. Complex case, 83 years old. You have already seen the result. A male presenting with silent ischemia. Exercise ECG was positive, plus. You see the BMI, a few cardiac risk factor, classic, renal function at baseline, okay, ejection frac 55%, was score 1.6% mortality at 30 days. That's the medication that the patient were using before some beta blocker and C. Okay, let's start with the image now. That's the most easy part of it. This is what we call the maximal intensity projection MIP from the multi-slice CT scan. If you make a quick exploration, I can see a stenose there, quite severe. This is calcified and also stenotic, the right coronary artery. The circumflex, you could see, was calcified and totally occlude. The LED is beautiful. We have already 60 patients enrolled. And believe me or not, the surgeon never asked to see the coronary angiography. So the feasibility so far is 100%. And you could see the surgeon like to see this LED. That's enough for him. He can put his bypass there. You could see clearly the total occlusion of the circumflex calcified, the narrowing in the proximal right with calcification, but also a soft lesion here in the right coronary artery, a small PD that would be a little bit challenging for the surgeon. And if you look at the main stem, a lot of calcification here, severe narrowing in the LED. You have already seen the total occlusion of the circumflex. Now, what the surgeon love is the volume rendering, because when they open the chest, this is what they see. They see the LED calcified, they see the intermediate here, which is a big vessel. They see the total occlusion of the circumflex. They can look at the posterolateral branch here. They can see that the PD is quite small. You can describe that with a still frame, but it's already done. And I mentioned that lesion in the right coronary artery, the small right, you will have to put the bypass somewhere here. The LED is going around the apex of the left ventricle. Now, this is quite visual, but the real thing is this. That's what we call multiplanar reconstruction. And every time at the heart team, we present that to the surgeon. And here the surgeon can see that he has a narrowing here, that he has in the proximal right, a good vessel initially, but almost completely calcified and narrow here, and then the very severe lesion distal. Yeah. Then you go to the circumflex, which is totally occluded, okay, but it's a nice vessel distally. This is the intermediate. This is the main stem. You don't see the circ, you don't see the LED. We select only in this multiplanar the intermediate, which is narrow, but the question is, do you have to do something about it? And again, this is the description with dimension. And finally, the LED, which has a severe narrowing here with ugly calcium. You see it's a very small lumen, a lot of calcium with blooming effect. And you will have to do this LED. So the point is we calculate the syntax score 35. You know that the European Society doesn't want to have multivessel disease with an anatomic syntax score above 22. Main stem could be 32, but three-vessel disease is 22. So that looks a little bit more for the surgeon. Now we got to the FFR CT. What is the function of this vessel? They are narrow, but indeed, they receive not enough blood. And you could see the fractional flow ratio less than 0.8, of course, in the right coronary artery, in the LAD. But look at the intermediate here. That's a vessel who does not need to be bypassed because it's still receiving enough flow. So you have seen that slide, you have seen the description, you use the smartphone. We have smartphone with the program of the Syntax Score 2020, who predict the 5 years MACE and the 10 years mortality. You have seen that slide. Clearly, there is still at that age an advantage to go to surgery. We can discuss that, but that's what happened, and the patient did very well. Now, what is new also in emerging in our practice is more and more the hologram. This is the radiologist who have looked at the film with us, Daniele Andreni, a good friend of mine. That's the surgeon on the way to the operative room. He has the glass here to see the hologram, and he see the heart that is going to operate. And that's during the operation. He can technically have the pictures just in front of him in 3 dimensions.
Right now we are recording. I can show. I can send you later this video. Cut smart.
So you see, we are all looking at these pictures hovering over the table of the heart team. You can see your colleague from India, which is behind the pictures. You can, with your fingers.
Stop recording.
Without
right now, we are recording. I can show. I can send you later this video.
Okay. And now,
cut smart.
Keep your fingers inside. Okay, and now you can move the hologram around. Okay.
Cut block.
If you take your second hand and do the same with 2 hands, you can enlarge the image. Oh, yeah.
So you see, I was doing some kind of, this is the patient you have seen. You can see a conus branch here. You see the right coronary artery, which is narrow at the side of these two ventricular branch. I mean, you have seen. You have the LAD, which is severely narrow on two places with calcium. There is a small nodule of calcium here and there, but a surgeon will not have too many trouble. And then I'm trying with my glasses, moving my head forward and backward to have a look at the circumflex. You remember the circumflex was totally occluded. So very quickly, I'm going back to the right coronary artery and then to the circumflex. I'll try to see the circumflex in more detail in a minute. Yeah, here you see the total occlusion of the circ here, very clearly, very visible. Yeah, so I don't need a cine angiography. I mean, this is 10 times better than the conventional cine angiography. And then it took me just like now a few seconds to understand the situation. So the plan based on CTA was a Lima on the LAD, a saphenous vein graft on the posterolateral and the PD. And indeed, the actual treatment was exactly the same. But I told you, we control these patients. So 30-day post-CABG, you have again the multi-planner to see how is the Lima. And you see the Lima as a beautiful anastomose on the LAD. And then we look also to the other bypass. You can see the saphenous vein graft on the right coronary artery, very high. As a matter of fact, I will be a little bit critical about the work of the surgeon in a minute when I will show you the hologram of that lesion. And then you see the situation pre-surgery, the situation post-surgery. You have seen our heart team. You have seen how I look just moving forward and backward. And this is after the surgery. So you see the Lima here with the clips going to the LAD. By the way, the saphenous vein graft is just behind. There is a small space between the saphenous. Here you could see the connection with the LAD, a good connection, well done. You see the saphenous vein graft behind the Lima. And here we have the saphenous vein graft going to the right coronary artery. You see they bypass that lesion, but they put this bypass a little bit high and at the side of some narrowing. So we will have to watch there very carefully. Again, if I move my head forward, backward, I don't have to do something. I can take my hands. I can rotate the image with my hand. The surgeon can do that in the operative room. Maybe he would have put the bypass a little bit more distal. I can also go into the structures as you see. So this is the top of the coronary artery disease. That's the 3-vessel disease with left main. If the fast-track CABG trial, and I told you we are halfway with 100% feasibility of the surgeon, if the fast-track CABG prove the feasibility and safety of non-invasive imaging guidance for CABG, then the surgeon in the future can, and will operate safely the most complex patient of the CAD pyramid with the sole guidance of CTA and FFRCT. And of course, the interventional cardiology should not have any reluctance in intervening on patient whose he knows in advance the anatomy, the functionality, and the tissue composition of the stenotic lesion, even before entering the catheterization laboratory, now upgrade into an interventional suite. The big question has been already confirmed 3-4 weeks ago in the New England CT or non-invasive or invasive coronary angiography in stable chest pain, CTA is a safe alternative to cardiac catheterization for patients with suspect CAD that will likely change clinical practice worldwide by replacing invasive testing in patients with stable chest pain. Multi-slide CT scan, a game changer that may change the gatekeeper. Will the interventional cardiologist remain the gatekeeper? Or will the cardiologist hybrid, the non-invasive cardiology, the general cardiologist, the general practitioner become the gatekeeper? We don't know. The serious conclusion is that using data from randomized trial and all-comers registry, we have updated and externally validated the syntax score 2020, a personalized predictive model based on 7 prognostic factors and 2 pre-specified effect modifier to predict 10 years all-cause death and 5 years MACE for patients treated with either PCI or CABG. And that's important, by providing expected probability of 5 and 10 years outcome, this model may improve the ability of the heart team to inform patients and their families regarding the risk and benefit of alternative treatment for complex CAD and support a more transparent, shared decision-making progress. Oh, sorry, I think something. Let me finish the last slide. So this is, I thank you for your attention. As you could see, we are in a beautiful place in Ireland, in the University of Galway. And this is all the fellows which are working with me. And as you could see, and I mentioned that at the beginning, at least on that day and during the picnic, there was 3 from India, but there are many more right now. I think that I really enjoyed their collaboration. And I think they are fascinating by the type of work that we are doing. Thank you very much.
Thank you, Dr. Patrick. I think it was a big eye-opener for many of us. Though I must confess that in last couple of years, I was spending a lot of extra time in the radiology department looking at the CT angios that were going on. So when we talk of this issue, PCI and CABG, my personal feeling as an intervention cardiologist is, you do CABG today, and after 20 years, if you have to do a PCI, it's far more difficult than to do a PCI today, 20 years later, CABG. Of course, you must keep a thought that arteries which need a graft, likely to need a graft in future, you don't stent the site which is likely to get anastomosis. So with this kind of thinking, I always felt that it's good to do a complex PCI train and preserve. Like in India, we get a lot of patients coming at age 40. So they would need 2 procedures. So which one first is what we are talking today. And I would probably feel that if we can get PCI first and reserve CABG for an age of 65-70, I think is generally a good strategy.
Yeah,
so,
I think that what you say is very important. Is of course the age, at which age do you start the symptom of your disease? You know, I belong to the generation who had to go to Zurich to see the first balloon angioplasty and bring back this balloon of 4.2 millimeters. So, before we get the 3.7. So, but the key point, what Andreas was saying very frequently, is that the interventional cardiologist should be seen as a dentist. You know, today you have a problem here, over 5 years you have a problem there, but you don't put immediately a rattle in your mouth, okay? So you keep that for late. So I think that if you see some kind of young patient, and you know, in the young patient, we have to check systematically LPA. You know, the LPA is really the bad guys, cholesterol, of course, but the LPA, I mean, is a quarter of the population in the world, a quarter, who has the LPA above 50 milligram. And that's the guy who comes with the disease at a very young age, and also myocardial infarction. So I think what is going to change in this decade is basically, you know, we had courage, we had ischemia, there will be another one, okay? And we interventional cardiologists has to realize that we have to combine that early treatment by percutaneous treatment with a very strong secondary prevention to avoid what you say, that later on you will have to use bypass surgery. So really we have to block the progression of the disease. And I must say, I may be naive, but I'm very impressed by the progress that we are doing. Just look at the American College of Cardiology. We had, of course, the PCSK9, and you know, in Oxford, we use PCSK9 in kids from 12 to 18 years old if they are hypercholesterolemia, familial hypercholesterolemia with father and mother. We have that. We have the PCSK9. We will have medication against the LPA. We will have medication blocking the interleukin. So I think that the mechanical part of it in the next 10, 15 years will become less and less. And you will say all these things cost a lot of money. But if you think, for instance, at inclisiran is 2 injections per year, subcutaneous. It's almost like a COVID shot, you know, boost 1, boost 2. I don't know when we are going to finish with these things. I think the world is going to change. And what is also quite interesting is that the great country like India and China, they are developing their own pharma product, their own device product. I mean, look at what you have in terms of valve in India. It's quite remarkable. So I really believe that the world is changing, and you know, we have not yet, but it's coming, eliminate the surgeon for the aortic valve, because you know the problem of durability is progressively disappearing. The durability of the surgical valve is now less than the percutaneous valve, but pushing the surgeon out, interventional cardiologists will also have to take into account all the powerful drug and start by a powerful secondary prevention. So I'm finishing by saying, I fully agree, at 40 years, you should not open the chest if you can avoid that. But that will be the moment to have a very, very strong prevention and see why this guy has developed that at that age. Diabetes, inflammatory process, hypercholesterolemia, LPA. I mean, that's obviously what we have to do here.
The other question, Patrick, which comes to our mind, and we face it again and again in our clinical practice, is the multivessel disease in a 40-year-old. How do we possibly take him to 85? If we do cabbage today, because it's a complex angioplasty, I think the progression of disease is very unpredictable in future. And we don't know at age 60, 65, whether he would need a repeat bypass or can be managed with an angioplasty. So I would probably feel at age 40, 45, most of the time we should think of angioplasty first and possibly be ready another 15, 20 years later for a possible bypass. And when we say this, the way we plan angioplasty, so don't stent the distal LAD and so on, leave it for the surgeon.
I must say I used to think like that. I used to think like that. But of course, in my career, I've done 4 trials with the surgeon, Cabri, Arts, Syntax, and Excel. And what I didn't have as a possibility of analysis, which is new for me, I'm like a student here, is that now I have 10 years of follow-up, and I look at what happens in 10 years, and I start to understand, even at the young age, who can eventually benefit. I didn't have data. I mean, it's amazing that after so long, I start to have this very long data. And I think that the last paper that I have been writing is not so much about surgery or about the PCI, it's about the geographic disparity between all the continent. You cannot talk about United States, Europe, India, Asia. It's not the same module. It's not the same model. I think the pathology will be at the end the same. I mean, it is cholesterol, LPA, inflammatory process, diabetes. So in the first place, that's what we have to treat. I mean, all these great Indian philosopher said always it's better to prevent than to cure. That will come. That will come. If you see also what Valentin Förster is trying to do in the children with primordial prevention, you know, very early age to say, you know, it's maybe better to have to be a little bit more vegetarian. It's maybe better to control your emotion in your daily life, and so on and so on. It makes progress. I think so. We are too old for that, you and me. But maybe in the next life we can change that.
So, do you need to use a very high-end CT for this kind of work, or conventional 64 or 128 slice CT?
You know, the technology, you know, the first time that we had a multi-slice CT scan in Rotterdam, I think was 86. And then we had a 1616, okay? And today you have a company like Siemens, who has now the new photon multi-slice CT scan. I've been very impressed by the improvement. You know, the picture that you have seen, that's much better than the angiogram downtown. That's point number one. Point number two, you know, in the British system, a multi-slice CT scan is 257 pounds, okay? In Switzerland, catheterization and senior angiography can be 2,000 euros. So we have to simplify the cost of our society. And if it can be a diagnostic tool and a decision maker and a treatment planner, I can tell you we can reconvene 5-10 years from now, but it's something which is moving in that direction, because the technology, like you said, I mean, I think the dual source 64 is already very, very good, yeah. And you know, there's one point which is important. I mean, the cath lab is an intervention place, okay? I hate to see this stick in the groin or in the wrist to find out a NOCA, you know? Yeah, that could have been discovered in another way. And that spare time in the interventional suite. We have to do cardioband, we have to do aortic valve, we have to do clips, we have to do many, many other things. So the time to spend 40% of the cath lab to do diagnostic procedure, where still today there is 40%. Patel is a great, he has published a lot about the fact that in the cath lab you have up to 40-60% of things, no PCI, no bypass surgery, nothing. Yeah, sometimes they give so that has to change. That has to change. Yeah.
At your center, may I ask, what is the proportion of PCI versus CABG today as compared to maybe 5 years back? And what is your prediction for the future? What is the trend?
You know, the PCI will stay still a long time, because basically your generation, my generation, yeah, we all end up with calcified things, and lithotripsy and rotablator, when it is well done, spare us to open the chest to have an anesthesia. You know, at a certain age, an anesthesia is not a good thing for the brain. We all know that. So that's where you need the good flair, and precision medicine is not mathematics. I mean, it's just a way to help us to think a little bit more in detail and help in the discussion with the surgeon. Many times I recuperate a patient who are going to do surgery because say, look at this, look at that, look at that. We are equipoise, why we don't do a PCI? Yeah, so it goes in both directions, and don't forget that. There is many places where the surgeon said, it's surgery. Sorry that you can defend your case and say, we believe that it will be equipoise for that patient, that individual patient, not two Kaplan-Meier curve getting separated and then boom, everybody goes right or left. That's not good medicine. Yeah. I'm a little bit provocateur, I know that. Yeah.
Yeah, so I think it has been an excellent session and an excellent presentation by Dr. Sares, where he has also given us a glimpse of the future. Though we would like to carry on, but it's always a pleasure to listen to Dr. Patrick Sares. But for the sake of time, I think we need to move on because we have Dr. John McMurray waiting at the other end for his talk. And thank you very much, Dr. Patrick Sares, for accepting our invitation and for time for our meeting.
Thank you.
It has been absolutely an honor and privilege to listen to you. So let's move on to the next talk. The next talk is by another stalwart in cardiology and by one of the biggest names in heart failure across the world, Professor John McMurray. It is indeed an honor and privilege to have Dr. McMurray with us today, and on behalf of CSI Pune, I extend a warm welcome to him. Dr. McMurray is a world-renowned cardiologist, and his resume, mind you, awards and achievements, runs in pages.
Why don't you catch up time by just letting me start my presentation, because we're 30 minutes late already.
Yeah, that's why I was coming to. I mean, I would not do justice to his achievements for the sake of time. So I would request Dr. McMurray to start with his presentation. The moderator for this session is Dr. Jagdish Hiremat, who is a senior interventional cardiologist of the city. And he himself has contributed a lot to coronary angioplasty, color Doppler, and heart transplants in Pune. So I hand over to Dr. Jagdish Hiremat.
Thank you, Dr. Sethi. Welcome, Dr. McMurray. I think heart failure managed in 2022 is far better than maybe what it was about 10 years ago. And I am looking forward in a very excited way to this presentation. Over to you, Dr. McMurray.
So thank you very much. So I'm going to try to give you a very rapid update on where we've got to in 2022 with the management of heart failure. So these are my disclosures. So this is what I'll talk about. I'll first of all talk about the way we differentiate amongst groups of patients with heart failure according to ejection fraction. And then I'll talk about the treatment of the major ejection fraction phenotypes. And lastly, I'll say something about treating patients who've been admitted to hospital with worsening heart failure. So just to make sure that we're all on the same page, as they say, these are the currently identified ejection fraction phenotypes, something we all agree on, which is an ejection fraction less 40% or less heart failure with reduced ejection fraction. And then patients who've got an ejection fraction above 40% currently divided into two groups, those with heart failure and mildly reduced ejection fraction, approximately between 40 and 50%, and then those with preserved ejection fraction, currently defined as people with an ejection fraction above 50%. And there's this additional group of patients who are becoming increasingly common, and those are patients with heart failure and improved ejection fraction. In other words, patients who had an ejection fraction below 40%, but with treatment have shown an improvement. And I'll come back to those later in my presentation. So let's talk about the type of heart failure that we know most about, patients with heart failure and reduced ejection fraction, in other words, 40% or less. So I'm going to base my talk around the two new major guidelines that have come out in the past 12 months, the European Society of Cardiology guidelines that came out last year and the American guidelines that came out about 2 weeks ago. And the major new therapy described in both of these sets of guidelines is, of course, the sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. They have come straight in with the strongest possible recommendation, a class 1 level A recommendation in this list of key therapies for patients with HFrEF. And the relevant text here is, I think, very clear. So unless there's a contraindication, and that means really only insulin, type 1 diabetes or a very low EGFR, unless these are contraindicated or not tolerated, then they should be used in all patients with heart failure and reduced ejection fraction. And of course, that's regardless of whether or not the patient's got type 2 diabetes. And the reason these drugs got a class 1 level A recommendation is because of these two trials, different agents in the same class, two separate trials, extremely consistent benefits, this 25% relative risk reduction in each trial, a large absolute risk reduction, small number needed to treat, early onset of benefit, as clear evidence as you could possibly get. And not just that, but there's also improvement in quality of life and symptoms and a slowing of the rate of decline in kidney function over time. So it's really the consistency of these benefits, the reduction in mortality, and the fact that there are two trials that account for the very strong recommendation. And this has just been replicated exactly in the American guidelines, as I said, released just in the past couple of weeks. The wording is almost identical. The level of strength of recommendation is the same. And again, in the American guidelines, you can see here this table of life-saving therapies. The American guidelines differ very slightly from the European guidelines in that they give sacubitril valsartan, an RNA, angiotensin receptor neprilysin inhibitor, a class 1 level A recommendation as well. So these are the core life-saving therapies, and you've seen figures like this probably many times by now. There are these 5 different pharmacological treatments that you can give in 4 pills, and this is now considered to be the bedrock of treatment for all patients with HFrEF, if possible. But maybe just as important as the entry of SGLT2 inhibitors so prominently into the new guidelines is also the changed philosophy about how to use all of these life-saving treatments, including SGLT2 inhibitors, because really there are 3 really fundamental changes in approach to using these therapies in the new guidelines. I have to say, much more clearly described in the American guidelines than in the European guidelines. First of all, the emphasis on speed. Secondly, an emphasis on initiation of all of these treatments before up titration of the dose of each of them individually. So prioritization to initiation of all of these therapies. And then finally, the idea that the order or sequence in which you give these drugs doesn't matter, that there's no fixed order or sequence which is preferred over any other. And really, it was the SGLT2 inhibitors that I think focused our minds on what we've been doing, because as you can see from this figure, and indeed the same is absolutely true from the Emcure reduced trial, the benefit in DAPA-HF of dapagliflozin was apparent within just 27 days of starting treatment. It was exactly the same, as I said, in Emcure reduced with empagliflozin. So these drugs work extremely quickly. Now, this is true of all of our treatments. I'll come back to that in a moment. But the SGLT2 inhibitors, with 2 trials coming so closely together, really made us think about what we've been doing, because this is what you might call the 2016 ESC guideline approach, this stepwise introduction of each of these treatments, starting historically with an ACE inhibitor, up titrating the dose before adding a beta blocker, up titrating the dose before adding an MRA, and so on and so forth, switching over to sacubitril/valsartan. And of course, if we had followed this approach in the 2021 guideline, we would be adding an SGLT2 inhibitor down here at the bottom. And this potentially could be as long as 6 months after starting an ACE inhibitor. And clearly, this would be delaying the initiation of life-saving treatment. So we realized that this approach is really no longer sensible, and that speed matters. Now, the other thing I mentioned was the prioritization of initiation of all of these treatments over dose titration. And part of the reason for that is because we also know that low doses have considerable benefit. You may get more benefit from titrating to the full dose, but even low doses of all the treatments we use are beneficial. And in fact, we went back and we looked at a very old set of trials, the CHARM trials, candesartan. Here you see the effect of candesartan, statistically significant within 2 weeks of starting treatment, and again, clearly different within 4 weeks of starting treatment. But look at the bottom of this figure here, and you can see that the mean daily dose at 2 weeks and 4 weeks was 4.7 and 8.5 milligrams respectively. Remember, the target dose in this trial was 32 milligrams. So again, very rapid onset of benefit, even at low doses. And that's why we've recommended prioritizing initiation of all of these treatments over up titration of treatments, because of course they all work independently. Nobody believes that a beta blocker works in the same way as an SGLT2 inhibitor. Their mechanisms of action are completely different. Their mechanisms of action are independent and additive, and that's the key word, additive. So of course, getting all of these treatments started as quickly as possible, we believe, is the best way to minimize risk for your patient. And because you get benefit even at a low dose of these treatments, it's more important to start all of them as soon as possible. And up titration of dose becomes the secondary consideration. And as I said, the American guidelines, I think, are much clearer about this than the European guidelines. And indeed, the American guidelines go as far as suggesting that at least for some patients, it may be possible to start some of these treatments simultaneously. Now, that, of course, is not going to be possible for everybody, but it is a very strong recommendation, and it is a very different recommendation from what we've been used to in the past. In the past, we've emphasized being cautious, being slow, doing it carefully, starting with very small doses, up titrating slowly. That has all changed. And the other key wording in this guideline, of course, is that the treatments need not be given in any particular sequence, and they certainly don't need to follow that traditional sequence that we used in the past. based on the history of the clinical trials. In other words, you do not have to start with an ACE inhibitor. Indeed, the only reason to start with an ACE inhibitor would be if it was the best tolerated or the most effective of the treatments that we have. And that's clearly not the case for either of those things. ACE inhibitors are not the most effective treatment we have. They're not the best tolerated. And therefore, there is absolutely no reason why they should be started first instead of any other treatment. Now, we've gone one step further than this recently, and we've actually modeled using the clinical trial data what might be the best way to do this and whether there would be any benefit from doing things differently than we've done in the past. And this paper will be published very shortly in the European Heart Journal. So here you see at the top here, the traditional sequence of treatments that we used. So what we've looked at is how many events could you prevent per 1,000 patients treated over the first 12 months of therapy. So looking here firstly at heart failure hospitalization or cardiovascular death in 1,000 patients in 12 months. So if you didn't treat these patients, about 280 of them would experience heart failure hospitalization or cardiovascular death using the traditional approach to therapy. So starting with a RAS blocker, up titrating over 6 weeks, adding a beta blocker, up titrating over 6 weeks, adding an MRA, up titrating over 4 weeks, and so on, we could, as you can see here, massively reduce the risk that these patients face. But what about simply doing it more quickly? What happens if we shorten the period in which we introduce and up titrate these treatments? Then we can prevent about 23 more people experiencing cardiovascular death or heart failure hospitalization. What happens if we skip starting with an ACE inhibitor and switching to an ARNI? In other words, just start with an ARNI, then add a beta blocker, then add an MRA, then add an SGLT2 inhibitor, further reduction in events. And then the most interesting thing of all, we modeled all the different possible sequences or orders in which we could use the drugs that we have available. And the one that was most effective in reducing events was actually to start with an SGLT2 inhibitor, add an MRA, then add a beta blocker, then add an ARNI, and then add a beta blocker. And compared to the 2016 approach, this actually could result in about 47 fewer patients experiencing cardiovascular death or heart failure hospitalization over the first 12 months of treatment. So 47 more events prevented. We did the same for all-cause mortality. It's a slightly different sequence down here, but it still starts with an SGLT2 inhibitor and an MRA. So doing it more quickly, starting with an ACE inhibitor, and maybe changing the order in which we give these drugs, you can actually have substantial additional benefits. Now, of course, that's a modeling exercise, and there are some other caveats, including the fact that, of course, it doesn't take account of how much all of that costs to do, but it is an illustration of how maybe we've not been doing it as well as we could in the past. So what else is new in the 2021 and 2022 guidelines? Well, there was another important trial that has resulted in a guideline change. That was the Victoria trial using a drug called vericiguat, which is a stimulator of this intracellular enzyme called soluble guanylate cyclase, increases cyclic GMP in the cells, and that has a number of downstream effects that might be beneficial. The Victoria trial was really quite different than most of the other trials that we've done in the past. This was a study in a very high-risk group of patients, all of whom had recently been in hospital because of worsening heart failure. And this trial was positive. The relative risk reduction was really modest. It was only 10%. the effect was just on heart failure hospitalization. There was no reduction in cardiovascular death, although because these were very high-risk patients, the absolute risk reduction was still important. The US Food and Drug Administration and the European Medicines Agencies have recently approved vericiguat to use in patients with heart failure and reduced ejection fraction, and the two new guidelines have incorporated vericiguat, but you can see here that the strength of recommendation is weaker. It's a class 2B, level B recommendation, so B because there's one trial. 2B means may be considered, so it's not is recommended, is not should be considered, may be considered, and that reflects the modest relative risk reduction and the lack of benefit on mortality. So this is really a second line treatment, but nevertheless, something that's good to have. So what about the remainder of patients? What about those with an ejection fraction above 40%? And the ESC guidelines really were very interesting when they were published last year, because for the first time ever, they included recommendations for some patients with an ejection fraction above 40%. And for those individuals with heart failure and mildly reduced ejection fraction, what was previously called mid-range ejection fraction, the guidelines included, as you can see here, a strong recommendation for diuretics, and then a 2B recommendation for neurohumoral modulating drugs, all the other drugs that we use in patients with heart failure and reduced ejection fraction. Now, these are all level C evidence recommendations. C, of course, meaning really consensus or based on other sorts of analyses. And of course, the reason why it's level C is that the recommendation is based on a retrospective analysis of the clinical trials that we have. And I've summarized those three analyses on this single slide. So here is a continuous rate of ejection fraction along the bottom of the slide. I've highlighted 40 and 60%. This solid green line is a continuous hazard ratio. The gray shaded area is the 95% confidence interval around the hazard ratio. And you can see here, for example, for candesartan, that the hazard ratio remains below 1, in other words, indicates benefit over placebo, with the upper 95% confidence interval crossing unity at an ejection fraction of between 55 and 60%. So in other words, there seems to clearly be benefit above the traditional threshold of 40%, and that benefit may extend as far as 55 to 6, an ejection fraction of 55 to 60%. And you can see a broadly similar pattern here for mineralocorticoid receptor antagonists and for sacubitril valsartan, based on the combined analysis of Paradigm and Paragon. So because of these retrospective analyses of these large combined clinical trial data sets suggesting benefit in patients with an ejection fraction above 40% and certainly up to 50%, the ESC guidelines made those new recommendations. Now, the ESC guidelines were published before one other critically important additional piece of evidence was presented and published, and of course that was the results of the Emperor Preserve trial. That was the empagliflozin trial in patients with heart failure and an ejection fraction above 40%. This was the sister trial to the Emperor Reduced trial, and you can see here that it was a very large trial, nearly 6,000 patients. These were the enrollment criteria: patients randomized to empagliflozin or placebo, the now usual primary composite endpoint for our heart failure trials. these are the patients who are enrolled, quite different than the reduced ejection fraction SGLT2 inhibitor trials. Patients were an average of about 6 to 7 years older. Instead of 25% women, 45% of the patients were female. They were very comorbid. About half had diabetes, about half had atrial fibrillation, and half had CKD, in other words, an EGFR less than 60 mils per minute. And interestingly, they were treated in a very similar way, in fact, to patients with heart failure and reduced ejection fraction. So this trial showed a 21% relative risk reduction in the primary composite endpoint, a large absolute risk reduction, a relatively small number needed to treat, and maybe the only caveat was that the benefit was really driven by reduction in heart failure hospitalization. There was no significant effect on cardiovascular death, although I have to say in this type of heart failure, cardiovascular death is relatively uncommon compared to heart failure with reduced ejection fraction. And you would need a really big trial to hope to show a reduction in cardiovascular death. There is one other recent trial in HFpEF with an SGLT2 inhibitor, much smaller trial, short-term study, only 3 months. Primary endpoint was symptoms, quality of life, and then this trial also looked at 6-minute walk distance, functional capacity. These patients had a really markedly reduced health-related quality of life. This is a very low baseline KCCQ, but as you can see, whichever one of these KCCQ subscores was looked at, there was a significant improvement with SGLT2 inhibitor treatment. And really, to my surprise, pleasant surprise, there was also an improvement in 6-minute walk distance, again, from a very low baseline level. These patients could only walk 244 meters in 6 minutes at baseline, and that distance was significantly improved by treatment with dapagliflozin. So more evidence that these drugs work in patients with heart failure and preserved ejection fraction. Of course, because the American guidelines were published more recently, after the Emcure preserved results were known, they have a somewhat different set of recommendations. So you can see here that they have given a 2A recommendation for SGLT2 inhibitors in patients with heart failure and mildly reduced ejection fraction, and they've given the same strength of recommendation for patients with heart failure and preserved ejection fraction. And then you can see that largely the other recommendations for heart failure with mildly reduced ejection fraction are the same in the American guidelines as they are in the European Society of Cardiology guidelines. But the recommendations for heart failure with preserved ejection fraction are really quite different. The ESC guidelines just recommends diuretics. That's the only recommended treatment in the 2021 ESC guidelines for patients with an ejection fraction above 50%. But you can see that the American guidelines are actually different and include not just an SGLT2 inhibitor, but also sacubitril/valsartan, an MRA, and if you don't use sacubitril/valsartan, an angiotensin receptor blocker. So this is the major divergence between the two guidelines. Now, the SGLT2 inhibitor recommend, I think, is just based on the time that the guidelines were prepared, but these recommendations for ARNIs, MRAs, and angiotensin receptor blockers are different between the two guidelines. So what about this other ejection fraction phenotype, so-called heart failure with improved ejection fraction? In other words, people who did have an ejection fraction below 40%, but have improved with treatment. And again, here, I think the American guidelines are good because they do include a recommendation and that recommendation is a class 1 recommendation, not to discontinue treatment. The recommendation is that treatment should be continued to prevent relapse of heart failure and relapse of left ventricular systolic dysfunction. And that, of course, is based on the TREAD-HF trial, which showed that if you do stop treatment in these patients, a very high proportion will relapse very quickly after withdrawal of treatment. So I think, again, a useful guideline recommendation that we've not seen previously. Now, before I finish by talking about hospitalized heart failure, I do want to remind you that we will be presenting the sister trial to DAPA-HF, which is the DELIVER trial. This is dapagliflozin in over 6,000 patients with heart failure and the ejection fraction above 40%. We will be presenting that at the ESC Congress in Barcelona in a few months' time. So we will be getting more evidence for heart failure with mildly reduced and preserved ejection fraction. So lastly, what about patients who have been hospitalized with worsening heart failure? Well, really, for the first time in many, many years, we now have a number of trials that are positive. Now, none of them are very big trials, but nevertheless, it's good that we're beginning to get evidence about what we should do in patients who've been admitted to hospital with worsening heart failure. Now, I'm not going to review all of these studies. I don't have time. I'll show you the 3 newest trials. I'm not going to talk about the PIONEER trial, which was published in 2019, but I will mention the SOLOIST worsening heart failure trial with sotagliflozin. And this is a study that enrolled hospitalized patients with heart failure across the ejection fraction spectrum. So this trial included patients with reduced, mildly reduced and preserved ejection fraction. They all had type 2 diabetes. They were randomized either in hospital or within 72 hours of discharge. And you can see here very clearly what we've seen repeatedly with this class of drugs, this very rapid onset of benefit, very large relative and absolute risk reduction. And the benefit was entirely consistent in the half of patients who were started on treatment in hospital and in the half of patients who were started on treatment after discharge. There was no difference between those 2 subgroups. And then more recently, we've seen another trial with empagliflozin, again, hospitalized patients, much smaller study, only 530 patients, again, covering the whole spectrum of ejection fraction, but a little bit different. All of these patients were randomized in hospital. They were randomized at a median of 3 days after admission. This trial included patients with and without type 2 diabetes, and it had a relatively short follow-up period. But even in that short follow-up period of 90 days, you can see that there was a significant reduction in death and worsening heart failure events. So 2 trials now suggesting that SGLT2 inhibitors are beneficial even when started in patients admitted to hospital, and most importantly, perhaps beneficial, most importantly, perhaps safe as well as beneficial in those patients. Now, what I think has maybe gone unnoticed in the ESC guidelines is the fact that all of those treatments we've talked about earlier, SGLT2 inhibitors, sacubitril, valsartan, mineralocorticoid receptor antagonists, and beta blockers are all given a class 1 recommendation for administration in hospital before discharge. And that recommendation has been reinforced, I think, even more clearly in the recent American guidelines. And again, the class 1 recommendation. And I think the wording here in the American guidelines is extremely important. It points out that when a patient's hospitalized, this represents a critical opportunity to either continue, so don't stop, initiate if patients haven't been started on treatment, or further optimize, in other words, if they're on suboptimal treatment, then improve it, guideline-directed medical therapy. And I think you cannot emphasize enough that hospitalization represents a critical opportunity. And it's very important, I think, also to read this very last statement, which is that it cannot be assumed that when a patient leaves hospital that they will have their therapy optimized. In fact, all the evidence is that unfortunately, after discharge, very little changes. So hospitalization identifies a very vulnerable group of patients and is a great opportunity to get these life-saving treatments started. So to finish with, I just want to mention intravenous iron therapy, a very inexpensive, readily available treatment, and one that I think is very valuable. We've known for some time now that in patients with heart failure, iron deficiency, and that's often without concomitant anemia. So you can be iron deficient and not have anemia. Iron deficiency is very common. It occurs in about a third of outpatients, at least in Western countries, and in about half of inpatients. We know from 3 different trials that intravenous iron therapy improves symptoms, quality of life, and functional capacity. And by the way, it is intravenous iron therapy. Oral iron does not work. So you must give iron intravenously. But what we didn't know until recently was whether or not iron might also reduce heart failure hospitalization and maybe even reduce mortality. Well, we've got the answer to one of those 2 questions from the AFFIRM AHF trial, which was published relatively recently. This was a modest-sized trial. You can see about 1,100 patients. All of these patients had been hospitalized with worsening heart failure. They had an ejection fraction 50% or less. Here's the primary composite endpoint. It's a recurrent events endpoint. It was borderline significant, but if you look down here at total heart failure hospitalizations, you can see that there was a substantial 26% relative risk reduction in heart failure hospitalizations. In fact, if this trial had used a classical time to first event endpoint, it would have been, even the primary endpoint would have been statistically significant. Now, obviously, this was a relatively small and relatively short-term trial. It had a fixed follow-up of 1 year, so there were not many cardiovascular deaths. And of course, this trial could not tell us whether or not cardiovascular death was different, but it did show a large and worthwhile reduction in heart failure hospitalization. There are more intravenous iron therapy trials underway, but both sets of guidelines do now recommend the use of intravenous iron therapy. It gets a class 2A recommendation in both the ESC and American guidelines. As you can see, the ESC guidelines, in fact, has 2 separate recommendations, one under this section of the guideline that specifically deals with hospitalized patients. So that was my quick speed through the recent updates and the guideline summary based on the evidence. So as I've mentioned, we continue to make progress in HFrEF, which of course we've done for maybe 3 decades now, but for the first time, we've begun to see progress in patients with heart failure and an ejection fraction above 40%. And certainly in many countries now, there is an expanded indication for the use of sacubitril valsartan. And I think even more convincingly, we've now seen that recent evidence for SGLT2 inhibitors from the Emcure preserved trial. So with that, I'll stop and thank you very much indeed for listening to this presentation.
Thank you, Dr. McMurray. It was as I said in the beginning, the heart failure management is going to be exciting in the coming days. And you made it so clear, so vivid, almost eidetic, that we could come to an elation or a conclusion that all 4 pillars of treatment must be included as early as possible, maybe lower doses, and improve on them as quickly as possible in the coming weeks. Even in hospitalized patients, we need to start them as all 4 doses. Low blood pressure is the Achilles heel that we face in management of heart failure with reduced TF, and that's why probably SGLT2 inhibitors have moved up the ladder, and also vericiguat is round the corner to combat these 2. And with this, including the IV iron, probably our management strategies and overall outcomes are going to be really good at the end of 22 and maybe in the years to come. Thank you very much for a wonderful lecture, which was absolute clarity of thought. And I'm sure it has immensely helped all of us and the audience. The question that I'm going to ask you is about beta blockers. Whether is there any, the first three beta blockers are well studied for the carvedilol, the bisoprolol, and the metoprolol. But is there any choice in your mind, or do you make the choice based on the patient? And if that's so, what is the choice?
Okay, thank you very much for the comments. So in the United Kingdom, where I work, we've only got available bisoprolol and carvedilol. We don't have the long-acting formulation of metoprolol. So sadly, I've got no experience with that. And to be honest, I don't really choose much between carvedilol and bisoprolol. Bisoprolol is obviously preferred in patients who've got concomitant chronic lung disease because it's a beta-1 selective beta blocker. Carvedilol has got alpha blocking activity, so at least initially it may lower blood pressure a bit more. So again, if somebody's got a borderline blood pressure, I'll probably go with bisoprolol over carvedilol. Bisoprolol is a once daily drug. Carvedilol is a twice daily drug. So if you think that pill burden and adherence is an issue, that might tip you in favor of bisoprolol. Bisoprolol is predominantly renally excreted and probably accumulates in patients with more severe renal impairment. So in somebody with renal impairment, you might think about, I would probably, if I had it available, use metoprolol because that's absolutely not renally excreted. Carvedilol is probably better than bisoprolol. So I think those are, at least off the top of my head, the major considerations, I think, in terms of choosing between beta blockers.
And how come, very surprisingly, there is just no mention of use of ivabradine in management of heart failure in the guidelines?
Well, ivabradine is in the guidelines. I didn't mention it today because it isn't one of the new, it isn't one of the recent updates. But along with vericiguat, hydralazine and isosorbide dinitrate, and even digoxin, we mustn't forget about digoxin, all of these drugs have a role, but again, they're secondary. So we have been very focused on those 4 pillars because those are the life-saving drugs. Those are the drugs that improve survival. Ivabradine, like digoxin, very useful treatment in select patients, but unfortunately, the evidence is that it doesn't reduce mortality. It does reduce heart failure hospitalizations, but it is, I mean, for example, if your patient can't take a beta blocker, say because of asthma, then ivabradine is a great drug, and I of course do use it. But I must say I don't use it very often, but I don't in any way want to say it's not an important addition to the tools that we have available.
We have a few minutes. So question, Dr. Rahul, you wanted to say something.
Role of flu shots and pneumococcal vaccine, whether should be given to all patients of heart failure?
Was the question about pneumococcal vaccine?
Yes.
Pneumococcal vaccine and
Yeah,
flu shots.
so-
Adult vaccination.
Yeah, so absolutely. So I don't know how it's done in India, but for us, it's a single once only vaccine. But of course, flu vaccine and pneumococcal vaccine are recommended in all the guidelines. Although I have to say, the evidence, of course, is not very strong, but we do recommend it. And I think, although it's to a great extent observational, it makes a lot of sense, and certainly is something that's recommended.
And it's recommended for all, I think, whether it's for heart failure or not.
Yeah, and
for the whole general population as well.
Yeah. I mean, we've even just recently published, our analysis of what happens to people who get pneumonia in clinical trials. And if you get pneumonia, you have a persistently long adverse trajectory. I mean, it's very interesting. Pneumococcal infection, for some reason, seems to result in some worsening of your prognostic trajectory, whether it's because of persistent inflammation after the infection's cleared or whatever. That's well known, I think, in coronary disease, but we seem to see exactly the same phenomenon in heart failure. So it makes sense to give pneumococcal vaccine, and it is in all the guidelines.
Shirish?
Thank you.
Yeah. With the advent of 4 pillars, is there any evidence that the need for CRT has gone down?
Very interesting question. So I have not seen that described for CRT, but I've seen it described for ICDs, and therefore I assume it's probably the same. Problem is CRT is an even smaller segment of the population. But yes, I mean, there's no question that the proportion of patients who remain eligible for an ICD has declined, and there's some recent data I've seen presented in abstract form. I don't think I've seen a paper showing that the numbers have declined, because there's no question, and I'm sure you've seen it in your own practice, that if you give all of the treatments we've talked about and you wait long enough, then ejection fraction will increase in a large proportion of patients to certainly above 35%. And of course, the issue, and in fact, we were just debating this very recently, is how long should we wait? How long should we hold our nerve before implanting an ICD? Because the temptation, of course, is to do it early.
Just a corollary. Sorry. Yes, go on, please.
No, I was just going to say, but we know that if you wait 6 months, the picture will be very different than if you just wait 1 month, because remodeling takes time to occur. And I think more and more the guidelines are moving in favor of a 6-month decision-making period rather than a 3-month decision-making period.
Corollary to this, improved ejection fraction, does it really change the prognosis of the individual? So are we categorizing from an ICD to a no ICD just based on the fact of improved ejection fraction?
Well, improved ejection fraction definitely changes your prognosis, but an improved ejection fraction doesn't usually occur by itself. So if you see a reduction, an improvement in ejection fraction, you usually see a reduction in NT-proBNP as well. And if you see both of those together, then if you enter the data into any prognostic model, you will see how really dramatically that can change your patient's anticipated prognosis.
Your experience with the use of isosorbide dinitrate hydralazine combination in patients with renal failure, especially with renal dysfunction?
Yeah, I have to say, even though the guidelines that I'm one of the authors of recommends hydralazine isosorbide dinitrate in those patients, I've not actually found it to be that easy to use, and I'm not convinced that it's very beneficial, but very often we don't have much choice. So we almost always try it. But I mean, I've certainly seen people who appear to actually have deterioration in their kidney function when they're given hydralazine and isosorbide dinitrates. Equally, I've more and more realized that I can use RAS blockers or sacubitril valsartan in people with kidney impairment without any significant worsening. So I think it all depends what you mean by renal impairment. If you've got somebody who's had an EGFR of 32 mils per minute for 3 years, you can almost always give them a RAS blocker and get away with it. But if their kidney function's been changing and that trajectory is downwards and it's occurring in a relatively short period of time, then that's a very different individual. So yeah, I mean, the guidelines recommend it. I do try it, but I'm, as you can tell, unconvinced about it. What's your experience?
One is forced to the wall when the, say, creatinine clearance is less than 20 ml. Then there's hardly any choice. But as you said, on the borderline around 30s, I would venture more into the ARNI group rather than the isosorbate dinitrate. And they also drop blood pressure quite a bit. So in people with low blood pressure, it's a difficult drug to use, the combination.
It's also, I mean, it's 3 times a day. In fact, maybe even should be 4 times a day. So it's a lot of pills. It's just, I find it not a particularly easy combination of drugs to use.
Any more questions? I think that's it. We've had a wonderful session on heart failure. Thank you very much, Dr. McMurray.
Okay. Thank you.
Over to you, Dr. Rahul.
Thank you, Dr. Jagan McMurray, and thank you, Dr. Hiremat sir, for moderating the session. For the sake of time, we have a last presentation by none other than Dr. Sunil Sate sir, and the talk is on ECG markers of sudden cardiac death. This is going to be a very amazing talk for, especially for physicians and cardiologists who are from peripheries. We have around still 900 logins for this talk. Dr. Sunil Sate, everyone knows, is a senior interventional cardiologist and electrophysiologist from the city.
Rahul, let's start.
Yes, thank you, sir. And to moderate this session, we have Dr. Chandrasekhar Makle, who is a deputy director, Ruby Hall Clinic for the last 3 decades. And everyone knows him. He has wonderful interventional skills and always being a bailout interventionist in cath lab. With this, I would hand over session to Dr. Makle.
Already running behind the schedule. Let me summarize Dr. Sunil V. Sate. SV Sate stands for super fast, versatile, and summarizing. So he will summarize today's topic of sudden cardiac death quickly. Sunil, over to you. SVS.
Thank you, Makle. This is actually perhaps the simplest talk of the symposium. You don't have to think too much. You have to just listen for 20 minutes. What I've done is, when you look at ECG markers of sudden cardiac death, if we look at the epidemiology, the risk subsets on ECG and the concept of cumulative risk. Look at the epidemiology. Remember, 80% of out-of-hospital cardiac deaths or in-hospital cardiac deaths, sudden deaths, 80% are ischemic, 20% are non-ischemics, males more than females, incidence more in blacks and athletes, and more the muscle, more the fibrosis, and longer the QT, severe the form, and more chances of sudden death. The next aspect of epidemiology is gender difference, men more than women. In women, in general, left ventricular hypertrophy changes with infralateral strain pattern and ischemic T-wave inversions are more as compared to men. In men, the depolarization changes of QRS duration and QRS fragmentation and the infralateral early reposition syndromes are more as compared to females. Now, the main idea of this talk is when we talk of ECG risk, how do we look at? We just don't go on looking at different ECGs. So we have to stratify them into 4 groups. a person who has increased incidence of sudden cardiac death is ACS. Second is on an ECG, what is the rate and rhythm sign which will tell me that, okay, this is a higher chance of sudden cardiac death. Then we look at inherited syndromes and depolarization and repolarization abnormalities on the ECG. So essentially, we are going to look from the ECG and try to predict the incidence of sudden cardiac death. To start with ACS, high-risk ECG and AMI. If you have a patient of acute myocardial infarction, there are 4 important signs. Remember, R-on-T phenomena, Lowndes classification was there for a long time. R-on-T phenomena today still there's a resurgence of interest. Still, it's true as a risk factor in an acute ischemic setting. So R-on-T phenomena in an acute ischemic setting, especially in the first few hours or days of an acute AMI. As the days pass, when the LV remodeling starts, then R-on-T phenomena starts losing its significance. So from anywhere between 6 days to 6 weeks, if you start getting R-on-T phenomena later, it doesn't tell you that, okay, this patient requires an ICG. So significance of R-on-T decreases as time passes. The next 3 important signs on an ECG, which I would look in a patient of AMI. The first is the sign is what is called grade 3 ischemia. See this. This ECG is grade 3 ischemia. The top ECG is grade 2, the gross ST segment elevation. But this particular sign was devised by Samuel Sklarowski. And this, if you have this sign on an ECG of an anterior wall AMI, be careful, keep the defibrillator near the patient, because this tells you the higher incidence of ventricular fibrillation pre or post thrombolysis. And I've seen this in several patients. So this is the first sign which predicts sudden arrhythmic death in a patient of AMI. The second one is the J-wave syndrome. If you get J-waves which are localized to the site of infarction, in this patient, it's in one enabel where the OM was occluded. Again, J-wave syndrome, again, it tells you that the arrhythmic potential or the arrhythmic risk in a patient with an acute AMI is high. So this is the second sign in a patient of AMI. The third, of course, is left main AMI. If you have ST segment elevation in AVR, but more important, right bundle branch block with ST elevation in V1 with significant ST depression in V2 and V3, this is an left main AMI in a patient with a dominant circumflex. So this, of course, higher incidence of cardiogenic shock, but higher incidence of sudden arrhythmic death. So these are the 4 pointers towards arrhythmic deaths in a patient of ACS from an ECG. Next, we look at the rhythm, rate of rhythm. Now, there were several trials, several papers, heart rate turbulence and heart rate variability. Now, we all know there are several papers. In isolation, they do not mean much. But since we do not use them in our routine clinical practice, I am moving forward to 2 simple parameters of rate and rhythm in patients, which will predict sudden cardiac death. The simplest one is sinus tachycardia, resting heart rate more than 100. It's a very important paper, 2020, which correlates admission AMI ECG, rest at rest more than 100 and ECG at discharge more than 100. Number 1, it correlates with a complex syntax score or higher syntax score. And number 2, a higher small incidence of arrhythmic deaths after discharge. And of course, in patients with LV ejection fraction, which is low, sinus tachycardia with a rate of 100 is a sign for, is one of the important markers for possible sudden cardiac death. The second simple parameter, which we all know, is on the Holter, evidence of non-sustained VT, ventricular ectopic burden 24-hour more than 25%. Now remember, there's a controversy here. Some people who are aggressive say more than 15% justify an ICD, but overall more than 25% is an important marker for sudden cardiac death. So these 3 markers, non-sustained VT, high ectopic burden, and a resting rate more than 100 in presence of LV systolic dysfunction are 3 important ECG markers for sudden cardiac death. The second clinical implication, not sudden cardiac death, of ventricular ectopy in a patient who has had CRT. Remember, if your ectopic burden is more, your response to CRT is going to be lower. So whenever you have put a CRT or CRTD in a patient with LV ejection fraction which is low, please see to it that the ectopic burden is not significant. Otherwise, the response rate decreases. These are the 2 important clinical points. From here, we move on on an ECG, clues from inherited syndromes, clues from depolarization abnormalities, and clues from repolarization abnormalities. Now, we know it's Brugada, LQT, short QT, arrhythmogenic right ventricular dysplasia, and WBW not as a genotype, but as a phenotype. We are not going to go into genotypes and phenotypes. I'll just show you the ECGs. We all know this. This is type 1, type 2, and type 3 Brugada. There is one sign which we know, this is one of our patients. There is one sign which is recent, which in a patient with Brugada, if you find wide and large S-wave in lead 1, it is a predictor of life-threatening arrhythmias, even when the patient doesn't have a history of sudden death in the family. So this is an important sign. This is one of the ECGs. Here, where in lead 1, you have a large, significant, and a wide S-wave. So S-wave in lead 1 in a patient Brugada is an important marker of sudden cardiac death in patients with Brugada syndrome. Second is ARVD. I'm mentioning this is if you have a right ventricular strain, that means T-wave inversion, especially giant, in a patient who is in patients when there is no ischemia, T-wave giant T-wave inversion V1, V2, in 3 signify either ARVD or severe pulmonary hypertension, especially in patients with pulmonary embolism. So in a young patient with palpitations, if you find T-wave inversion in V1, V2, V3, please look for an epsilon wave. Epsilon wave is a hallmark of ARVD. It's not only for ARVD. This is a wave which is at the end of QRS and beginning of T-wave. Now, the important point is, in a young patient, if you find this, then of course, it's a risk marker for sudden cardiac death in patients with ARVD. And of course, you must put an ICD in these patients. The problem with epsilon wave is that the sensitivity is low. So sometimes you have to use the Fontan lead to get the epsilon wave, usually seen in right-sided leads. V1 or right-sided V2 and V3, or the Fontan lead where it is picked up better. So V1, V2, V3 T-wave inversion in a young patient palpitations, look for epsilon wave on the ECG. The other syndrome interesting is familial cardiac arrhythmic syndrome. If you have significant ST segment depressions overboard, which are marked, persistent, and non-ischemic, that means the angio will be normal. This is what you have to be careful with sudden cardiac death. And this is one of the ECGs. If you look at this ECG, V1 ST elevation, AVR ST elevation, and ST segment depression. This is what we classically teach patients is likely to have triple vessel disease or a left main. These patients will have normal coronaries. So persistent ischemic changes with normal coronaries, be careful. It's an important sign for a sudden arrhythmic death. Besides genotypes in mutation, a commonest is pre-excited atrial fibrillation, fast, broad, irregular, no IV AV nodal blocking drugs, no oral AV blocking drugs, because they can fibrillate and die. So you must send these patients for ablation. Many times it may not be atrial fibrillation, and we had this patient who had antidromic tachycardia pre-excited. Patients, we were not sure if it was VT or what it was, a young patient. So obviously, young patient, normally we don't expect VT. So this was an antidromic tachycardia. By the time the patient was wheeled into the CCU, he went into ventricular fibrillation. He was shocked, he survived, and we did an ablation in this patient. So important pre-excited atrial fibrillation or antidromic tachycardia in a young patient is an important sign for sudden cardiac death, and treatable and curable. So you must be aware of this. From there, we move on to depolarization abnormalities. Very simple. If you find Q waves or QRS score, they are likely to have more re-entrant arrhythmias. QRS duration, only duration more, it facilitates re-entry. QRS fragmentation, it causes inhomogeneous myocardial conduction and re-entry. And hypertrophic states, LVH by voltage or increased ventricular mass, it causes abnormal electrical remodeling. So all these four from an ECG will tell you that depolarization abnormalities are risk markers for sudden cardiac death, out of which duration more than 160 will increase all-cause mortality and sudden death in a patient with LV systolic dysfunction. There is no correlation, however, between QRS duration and inducibility of VT. Why I've mentioned this is previously in patients with LV dysfunction and wide QRS, we used to do VT studies to find whether the tachycardia is inducible before putting an ICD, but that's no longer required. So QRS more than 150 milliseconds, besides your CRT for LV function, you have to be careful for sudden cardiac death. Next, important depolarization sign is fragmented QRS. Any patient with bundle branch block, ectopy, or paste QRS, if he has more than 2 notches in the R or S in leads, 2 consecutive leads, V1 to V5, lateral or inferior leads, this is a fragmented QRS. What does it represent? It represents conduction disarray due to myocardial fibrosis, especially in patients with QRS more than 120. Different morphologies. How did it start? In the ICD arm of SCADEF trial, it was shown that patients with fragmented QRS had more shocks. So in fact, amongst all the depolarization abnormalities, this is one abnormality which is very, very specific. And I'm showing you different forms of fragmentation. This is with RBBB, this is with LBBB or paste beads, and this is with ectopic beads. Whenever you find fragmentation, please, and the important point about fragmented QRS is that it is an important marker in all spectra. That means if you have a ischemic or a dilated cardiomyopathy, broad QRS, fragmentation, increased death. If you have Brugada, fragmentation, increased death. If you have LVH, fragmentation, increased death. So out of all the markers, this is an important marker to watch from. And one interesting paper which was recently published is fragmented QRS in patients with acute ischemia. You have reperfused by thrombolysis or a angioplasty. Remember, at discharge, you find mild QRS widening or a wide QRS with fragmented CAD. Be careful. It tells you that the myocardium is not being reperfused despite that you have put a stent in the epicardial artery. So they have more chances of arrhythmic deaths and cardiac mortality. So in a patient with elevated systolic dysfunction, in an acute ischemic setting, if you find fragmentation post-procedure, you have to be careful for sudden cardiac death, especially in the first month after reperfusion. Coming to the last depolarization is hypertrophied hearts. Left ventricular hypertrophy with strain, infraventricular significant ST segment changes cause adverse electrical remodeling. Now, if there is only ECG change, they are more prone for atrial fibrillation. If you have ECG change and increased LV mass on echo, so for example, the normal in males is 135 grams, it is more than 200, or if the mass index, that means per meter square more than 100, normally 71, then with significant strain pattern and increased mass, especially in a patient who has ventriculectomy, this is one of the important signs for sudden cardiac death in patients with hypertrophic hearts, with patients with hypertension or any other cause. That's important. So in fact, LVH and increased ECG changes on ECG and LV mass actually increases total mortality, cardiac mortality, and higher incidence of sudden cardiac death. And there's a recent paper which says that if you really find a regression of LVH on an ECG or LV mass on an echo, it decreases the incidence of sudden death. So simple LVH with LV mass is an important sign for sudden cardiac death. The next hypertrophic syndrome is, of course, hypertrophic cardiomyopathy. What are the ECG signs on? What are the signs on ECG? We tell you a higher incidence of sudden cardiac death. In a patient with HCM, QRS duration of more than 120, significant ST segment depression more than 2 millimeters overboard, dominant S wave in V4, a pseudo-STEMI pattern. That means V1, V2, V3 looks like an infarct, but actually it's not an infarct, normal coronaries, and large significant pathological Q waves in multiple leads. And the most important interesting feature, the last one, is low QRS voltage. In an hypertrophied hearts, we always expect high voltages. So in a patient with hypertrophic cardiomyopathy long-standing, if you find that the QRS voltages are low, please remember this is an important sign for important marker for sudden cardiac death. So these are the important clinical signs in patients with hypertrophic cardiomyopathy. Coming to repolarization from an ECG, I would look at the QT, the QT, QTC, T2E peaks, early repolarization syndrome, and QRS angle. I'll just tell you simple practical points. QT prolongation, important risk marker, subset important, congenital, acquired, drug-induced. We are not going to go into phenotypes and genotypes. An important clinical point is what is called rate dependence. Now, the two common drugs which we use in our clinical practice is sotalol and amiodarone. And what's the difference? Amiodarone has a normal rate, that means rate dependence, means at normal heart rates or increased heart rates, it has the maximum effect on QT, it will prolong the QT. As against sotalol has what is called reverse rate dependence, means sotalol will increase the QT at a lower rate, and sotalol inherently causes bradycardia. So patient on sotalol, in fact, you have to be more careful because sotalol is more active at lower rates. So for a torsad, between the two, you have to be more careful in patients with sotalol to look at QT interval as against amiodarone. So this is the clinical importance of rate dependence and QT interval. And the second important is, besides the QTc more than 500 is a severe form, but more important practical point is when you have depolarization abnormalities on the ECG, that means LBVB, RBVB, a wide QRS, and the QTc is not accurate, it is fallacious. And in this setting, you must look at the JT interval, or what is called corrected JTC. So if you find from J point to the end of the wave, JT interval is more than 320 in these patients, you have a higher risk of sudden death. And this is important because suppose you have a patient with a broad QRS, the broad QRS itself is a risk marker. And on that, you have increased JT interval, then this is a double-edged sword. You have to be very careful. The patients are likely to have a higher incidence of sudden cardiac death. Short QT less than 280 or QTc less than 340. Remember, there's a recent paper from Cleveland Clinic which says in a normal healthy population, only a short QT when the acquired causes are ruled out, that means no hyperkalemia, no hypercalcemia, no hyperthermia, no GTRS, no nicorandil. All these will cause short QT. But when these are not there in the normal population, it may not signify sudden cardiac death. But if you have a high incidence, if you have a history of sudden cardiac death, history of syncope, or genetic results are positive, then short QT. So at least on ECG, we must learn to look at the QT interval. If it's short QT, we must be aware that in a subset of patients, it can cause sudden cardiac death. Repolarization abnormalities, QRST angle just mentioning, QRST angle more than 120, macro or microscopic T-wave alternance, especially macroscopic, we have an alternate T-wave, short and tall, and T peak to T end, more than 90 milliseconds. These are the three simple repolarization abnormalities on an ECG, which are one of the factors. They are by per se, individually, they may not have high specificity, but we must be aware of these three important signs. Early repolarization, usually benign prognosis, but is a variant which has a mutation in the L type or calcium channels. There is a malignant phenotype, unclear whether it can use a risk mark, but there are some signs which will tell you that what is malignant early repolarization and what are the signs? Early changes in inferolateral or global leads. Find that you have early repolarization like syndrome in global leads, notch terminal of waves in QR. That means you have a fragmented terminal QRS, a J wave amplitude, that elevation more than 0.2, or a horizontal ST elevation rather than ascending ST elevation. If you find these four signs, then in a young patient, when we say, oh, it's okay, it's repolarization, you must be careful for sudden cardiac death. And this is one of our patients where you find that this is seen in global leads. The J point was much more than 0.2. So this is one of the ECGs of a malignant in early repolarization syndrome. Finally, the concept of ECG marker for SCD as a concept of cumulative risk. That means when we just keep on talking of single marker concept, the specificity and sensitivity is not good enough. So people have tried to have different facets of the cardiac electrical actions and develop electrical score. And what they see is whatever we have said, from repolarization to depolarization, try to find whichever signs are there and try to find a risk score. Now, there are several risk scores. I'm just showing you one. In general, these risks are important when you want to predict better the predictability for sudden cardiac. But in general, as we all know, scores are never used in clinical practice. So it is just to tell you that, yes, risk scores are important. But here, forget the score. At least you find that if you divide this patient into ACS, rate and rhythm abnormalities, depolarization, repolarization, and if at all inherited ECG syndromes, then at least you will be aware that this person has a higher incidence of sudden cardiac death. Finally, a high-risk subset, coming back to the high-risk subsets, as I said, ACS, pre-excited atrial fibrillation. One I have just mentioned here, AV junction ablation with permanent pacemaker. Now there's a resurgence of this concept lot of papers in the last 6 months with patients with congestive heart failure. If you have atrial fibrillation with uncontrolled ventricular rate, please do AV junction ablation and a pacemaker. Here, of course, you have to be careful keeping the pacemaker rate normally for the first few weeks more than 90, otherwise you can have sudden death. So I've just mentioned this. And of course, LV systolic dysfunction is perhaps the commonest suspect where I would like to predict sudden cardiac death. So the final slide is because it's the commonest subset in clinical practice. So patients with LV systolic dysfunction on an ECG, fragmented QRS, broad QRS more than 160, ectomy burden more than 25, non-sustained VT on Holter in a patient, especially with EF more less than 25 and fibrosis on MRI more than 20%, this is a harbinger for sudden cardiac death. So perhaps this is the commonest subset. So I've just given you as this last slide. So in conclusion, ladies and gentlemen, ECG is a simple tool to initiate the process of risk stratification for sudden cardiac death. Categorization of subset is important. And that's why just showing the signs is not important. I would like to see whether it's ACS. I know my 4 signs. I would see the rate, the sinus tachycardia, from sinus tachycardia to Holter signs. I would like to know depolarization abnormalities in the patient with LV dysfunction and repolarization abnormalities. So I would look. So overall, individualized ECG markers have a low to moderate sensitivity specificity. So except for a few signs, the concept of cumulative risk and electrical score has come, because I would like to see all these signs, and together, if you really put one and one together, we can actually predict more sudden cardiac deaths. So awareness of ECG markers is more important than individual Stein statistics. But this lecture is just to make all of us aware that yes, I can predict sudden cardiac death with reasonable sensitivity and specificity, especially if I categorize my patients and try to see how many signs this particular patient has. Thank you very much.
Hello.
Thank you, sir.
It was a very excellent presentation, and you have shown how the simple tool ECG can definitely help the clinicians to predict for the sudden cardiac death. Rahul, can I continue?
Yeah, please.
Yeah. Now, one question for Sunil. That many times we see the sports person suddenly dying on the field while playing. Are there any ECG predictors for athletes for the high risk sudden cardiac death?
See, basically the problem with competitive sports or athletes is that they are at a very high adrenaline drive. So the problem is not really signs or an ECG, but at least once people in competitive sports should have an ECG, an echo, and a stress test. This is never done, at least an ECG. So at least the markers, because if you have a high adrenergic drive and if you have a milieu, like a hypertrophic heart, hypertrophic cardiomyopathy, or catecholamine-induced adrenergic ventricular fibrillation, then there are chances of sudden death. The problem is even the simple tools of screening are not done. That is why the incidence in athletes is high. But these are the 3 simple things which at least once all competitive sportsmen should have.
Then you also mentioned about the EV junction ablation and permanent pacemaker implantation. But what is the risk and how long, means what is the longevity otherwise?
See, here what happens is, suppose somebody
atrial fibrillation, the atrial kick is lost.
See, here the problem is not atrial kick. It is basically the patient is in atrial fibrillation with a ventricular rate of 120 to 160, uncontrolled. Suddenly the rate comes to 60 or 70 pace rate. So the repolarization of the ventricles doesn't cope up with sudden rate change, and that is why you get this reentrant tachyarrhythmias. So that is why what has been mentioned is at least for a period of 2 weeks to 4 weeks, 1 month at least, keep the pacing rate at 80 to 90. When you ablate the AV node, overall the remodeling starts, the repolarization remodeling starts, then of course you can get it back to 60 or 70. So the incidence is not less. Almost up to 2% patients can have sudden death after this procedure in the first 1 month of this procedure.
Now, these patients with the hypertrophic cardiomyopathy, for the years together, we have learned those Yamaguchi sign and all those LVH criteria, etc. But this low voltage, is it because of the fibrosis which is happening or anything else?
Correct. So basically, there are two mechanisms mentioned, and it's an important sign. The more the fibrosis, especially if you see MRI fibrosis more than 25%, you will find that the voltages are low. And there's one category, low PC, rare hypertrophic cardiomyopathy going into late in stage dilated cardiomyopathy with decrease in LV ejection fraction. These are the two actually subsets. We will find that the voltages are low as compared to the hypertrophy which we expect, and the hypertrophy given the ECG signs on the ECG.
Okay. Any other questions by any clinicians?
People are now hungry.
It's already, I think we are overshooted by 20 minutes.
Yes.
So Sunday, you have done a wonderful job and I must congratulate you. And I think this presentation, all of them should keep and practice it in their day-to-day practice. Particularly post-MI, while discharging the patient, they should look at the ECG in details. Thank you. Over to you, Rahul.
Yes, sir. So thank you very much, sir. I think we are at the end of our academic feast. So I take this opportunity to conclude this talk and this meeting. So it is my immense pleasure to conclude this academic feast, which has attended by more than 1,400 delegates across the country. All of them, almost for last session, there were around 850. And we had 6 presentations equally distributed among 3 international and 3 national speakers. We got the great insight on present and future of cardiology. Dr. Patrick Serre's presentation was outstanding, showing the future of cardiology and probably angiography going out of the hands of interventional cardiology. I would also like to thank all the moderators who spare their valuable Saturday evening, and special thanks to Dr. Sunil Sathe sir, Dr. Jagdish Hiremat sir, who was driving all the way from Satara and logged in time in the car and was throughout the presentation with us. Thank you very much. It won't be justice if I don't thank our generous president, Dr. Rajiv Sethi, who was a source of inspiration and helped me throughout organizing this CSI event. Last but not least, let me thank our Emcure Pharmaceutical and Mrs. Pavita Thapar, who was partner throughout this meeting and last year. So with this, I would like to conclude this meeting, and also would like to announce one more that we have next meeting on 17th of May, which is 3rd Tuesday, and we have a presentation by an international speaker, Dr. A. Sri Radna, who is a pioneer in drug-eluting balloons, and this session will be moderated by Dr. Jagdish Hiremat sir. So 17th May, 8 p.m. I welcome all of you. Thank you. Stay safe and good night. Thank you.